Dr. Ved, should we start? So should we start? You are on mute.
Yeah, please start.
Okay, great. So good evening, everyone, and welcome to the webinar on PGT and dilemmas. I think one of the most hot topics that is in discussion right now, especially when it comes to ART. So let me welcome the conveners for the day, Dr. Ved Prakash, who's the newly appointed president for ACE and the lab director for South Infertility and IVF. Dr. Sanjay Shukla, who's the lab director for Bahiti Hospital, Shivani IVF and Fertility Center, and Dr. Charudutt Joshi, the medical director for Genes India ART. So Dr. Ved, Dr. Charudutt, and Dr. Sanjay, I leave it to you to carry on the webinar further.
Thank you, Shipra. So here I am to share my screen. I hope it is visible now, no? My screen is visible? Hello?
Yes, sir, it's visible.
Yes,
sir.
Yeah.
You can just maximize the screen. Maximize the screen.
Yeah.
Yes, perfect.
So on behalf of iHERA and CooperSurgical, I welcome all of you. As you know, we are regularly organizing online activities absolutely free for everyone. And we are committed for sharing the knowledge. And thanks to CooperSurgical, who is supporting for this webinar. Us and iHERA is an online academic platform. And we are doing some activities like some small courses, everything. And we have advisory panel, national, international. You can see here, these are the international panel, and our team leader was working very hard to fulfill these activities. And this is our today's webinar. And recently, iHERA team published one chapter in a book, and you can find us on this website. This is our contact. Anybody who want to share their topic, everything, we can always welcome all of you. Anytime you can contact us, and any topic you want to one webinar on that topic, we can organize for you. So I hand over this to my friend Dr. Charudutt Joshi. He will introduce our coordinators.
Hello. Hello, good evening, friends.
Sanketh, can you please?
Hello, am I audible?
Yes,
you are. Yes, you are.
Yes.
Sanketh.
So, good evening,
yeah, I'm sharing the
everyone.
Screen,
Yeah, it is once again my pleasure to invite all of you on this academic platform. And it's my pleasure to introduce our team leaders, as we always do in the beginning. Mr. Rahul Sen is presently working as chief embryologist in Nilkant Fertility, Rajasthan. Rest everything we all know about him. So the second is Dr. Sanketh Satya. He is also one of the great leaders now. Till now, iHERA has taken up in very nice way. He is also working as chief senior clinical embryologist in Shema IVF. And our third, least but most important, is Dr. Akash Agarwal. He is ISHRA certified clinical embryologist and is practicing male infertility and embryology since 2011. And he is a scientific director at Headgear Fertility, Hyderabad. So welcome all of you, and I now hand over to our team leaders to take the proceedings further.
Thank you, Charu sir. Thank you, Ved sir, and thank you, Shukla sir. So, very good evening all. So, I'll be introducing moderator for today's first lecture. So, that is Dr. Krishna Mantravadi, dear senior friend of mine, and currently is working as a scientific director at Oasis Center for Reproductive Medicine, Hyderabad. And He holds a master's in clinical embryology from Monash University, Australia, and he also holds a postgraduate diploma in reproductive sciences from Monash University, and he has done his MBBS from Rajiv Gandhi University, Bangalore, and advises his main areas of work are cryobiology, in vitro maturation of oocytes, andrology, and men's health. Currently, he is also working on employing newer techniques to improve the success rates of IVF in PCOD and recurrent IVF failure patients. So without taking much time, Krishna sir.
Yeah, thank you, Sanketh, for that elaborate introduction. So let me take the honor and pride of introducing today's first speaker, Dr. Fiona De Souza, a very good friend and a wonderful academician. She's a proud alumnus of Manipal University, and she's currently heading the as a scientific operations of the Anderson Diagnostics and Labs. So she's here to enlighten all of us on those little tips and tricks as to how do you get the best tissue in difficult situations of a blastocyst biopsy. So without further delay, Dr. Fiona, the floor is all yours. Looking forward to get some wonderful practical inputs.
Thank you so much, sir. First of all, thanks everybody for having me here. And let me just share my screen. I hope it's visible.
Yes, it is.
Right, okay. So my topic for the day is how to maximize retrieval of embryo biopsies in difficult situations. I have strayed a little bit away from my topic and covered a little bit more, so please excuse me for that. So as we all know, pre-implantation genetic testing is something that's gaining track in India now. The acceptance is quite more, and its steps are pretty straightforward. We use culture embryos until day 5. They are biopsied. The biopsies are shipped to the genetics lab, where the entire genome from those 6 to 8 cells is amplified by a process called whole genome amplification or bridge amplification. Further, the samples are processed by NGS and undergo data analysis by bioinformatics softwares, followed by report generation. So let me just begin with the requirements you need for embryo biopsy. If you are somebody new who is planning to start embryo biopsy in your center, what we usually prefer is ICSI-derived embryos for PGT. We, of course, require a laser, biopsy medium. We need to procure biopsy needles. Handling pipettes are usually something that you usually do use in your IVF centers, and sterile microtips. So ideally, we use about 8 ml of oil for every 2 embryos. That is how we calculate beforehand. And the culture medium for embryo biopsies depends on the center preference. You can either use a herpes buffered medium, MOPS, or the blastocyst culture medium if you are able to do a quick biopsy. PVP, of course, is the same PVP we use during ICSI. A point to be noted while picking up biopsy needles is to make sure they match the angle of your holding needles that you usually use during ICSI. So in case you use a 35-degree angle, the same would apply for the biopsy needles. So the main things required for ideal hitch-free biopsy is your micromanipulator. If you have a very outdated micromanipulator or it has not been serviced recently, this is the biggest hiccup we will face. So an ideal thing would be to, at least a day before or two, make sure that your instrument is calibrated, the injecting and holding are functioning smoothly, optimally, and make sure there are no air gaps or debris in that could obstruct the injecting or holding pipelines. Of course, you need a fully functional laser. Make sure your software is not hanging. Make sure your laser is aligned properly. If any of these things are not functioning optimally, contact service engineers and get them done straight up right away. Consumables and micropipettes are another thing. Also, please ensure that there are no construction activities, repairs, drilling, or an impromptu electrical work happening that would interfere with your IVF lab. The main precautions we take before performing biopsies is to avoid exogenous DNA contaminations. So we begin with mainly establishing a very clear and precise SOP for the biopsy, right from preparing your equipment till shipping the sample. If you're a new lab, we suggest you discuss with your genetic service provider to go in for a dry run at least to make sure you know how the procedure works and all your people are ready for it. Of course, everybody's quite excited when it comes to planning a biopsy cycle in a new center mostly, and everybody wants to have a look at it, from the juniors to associated people in the labs. But in order to avoid external DNA contamination, it is always preferable to have minimal number of people in the lab, so it is restricted to essential personnel only. 70% alcohol is something that we do not advocate. As embryologists, we stay quite away from it, and we do not require to use 70% alcohol to clean the facility. We would prefer using USAFE, and maybe if you would have a portable UVC light, you could turn it on facing towards only the laminar airflow and not your incubators. And many people are used to keeping a lot of things in your laminar airflow. So before you plan a biopsy, ideally stick to minimal requirements only, just the pipettes that you need, the strippers that you need, the pipette tips that you need, and the biopsy kits. Another thing you need to remember is, though we prefer to keep embryos always at 37 degrees Celsius, biopsy itself maintained at room temperature. This is because once we do the biopsy, it's sitting in a dish which is not overlaid with oil, and evaporation at room temperature might impact the viability of your biopsy cells. It is well understood that personnel who are in the laboratory during the biopsy procedure are expected to wear full protective clothing with hair cover, head cap, face mask, gloves, etc. The gloves we use should be perfectly fitting you, should be non-powdered, and should not be those vinyl gloves that fit very loosely. Just a quick look into day 3 biopsies. Of course, none of us prefer it anymore. We thoroughly discourage the use of it, but for those who are interested in it, a magnesium-free cell culture, free culture medium is used for day 3 biopsies. A single blastomere needs to be aspirated. In case of a lysis, a second biopsy needs to be done. You need to make sure a very clear nucleus is visualized in the blastomere that is biopsy. Fragmentation greater than 35% is not advisable to use for an embryo biopsy. Of course, it does allow us to detect both maternal and paternal related aneuploidies in the embryos, but the high level of mosaicism in day 3 embryos does discourage us from using it for biopsy. Another limitation is that we do not know which cell we are removing, and cell-fate determination happens a little later. So we might be depriving an embryo of ICM cells. So that is one of the main reasons we do not prefer day 3 biopsies. Also, to feature in self-repair mechanisms, which have this is a hypothesis that's been around for a while now. And of course, we have evidence for it because of confined placental mosaicism that we have seen in postnatal cases. Also, the use of magnesium-free culture medium may impact compaction, and the drill site might cause any other additional blastomeres to seep out during the embryo development. And you would end up with more embryos to biopsy on a day 3 than a day 5. That means an additional financial burden to the patient. So coming to day 5 biopsies, this is our preferred stage for embryo biopsy right now, between day 5 to day 6. So selection criteria plays a critical role in the outcome of the PGT report. We usually prefer the best quality 4A embryos for biopsy. Always embryo with a very small ICM or a very poor quality trophectoderm is discouraged from using for biopsy. We should always make sure that during biopsy, as you can see in figure C, you have one bunch of extruded cells at the bottom, and another additional cell which looks away from the embryo. So these kind of cells have to be avoided during the biopsy because they're most probably going to be aneuploid. If there are any cumulus cells, most unlikely at day 5, but sometimes we do see them, please avoid entry of the biopsy pipette from that particular location. In case you do have an embryo that has not fully expanded and not hatching, like in figure B, ideally wait for it to expand. Maybe it might take until evening, maybe it might take until the next day, but better to wait for it, make sure that it's an embryo that you would want to biopsy, and then proceed. So in figure A, you can clearly see that the hatch point is very close to the ICM. So this might happen in early embryos, or in case you have hatched the embryo on day 3 or day 4. And ideally, figure A is not our preferred location to enter the embryo. This is mainly because we are too close to the ICM and we do not want to damage it. When it comes to selecting needles for biopsies, you can use a slightly wider biopsy for completely hatched biopsy needles for completely hatched blastocysts compared to hatching embryos. So another question comes is, should I biopsy a completely hatched embryos? And many embryologists are quite apprehensive in doing so. So the point is, they are very delicate. The pressure controls of your holding plays a critical role here. And you have to be very, very careful while doing the biopsy. But yes, it can definitely be done. And no, it does not impact implantation potential as different than a standard hatching blastocyst biopsy. However, you can see in figure B that the holding point is very close to the ICM also. So in these cases, it would be preferable that you hold the ICM preferably at the 10 o'clock or 8 o'clock position, as opposed to a direct near the ICM position. And then position your injecting needle accordingly. So coming to biopsy techniques, we can either use a complete laser based biopsy with stretching. So the first 3 images are an example how we use laser and stretching technique. What I would like to emphasize here is the number of laser shots that you would ideally use. Now, the laser shots, if they are directly shot on the embryo, would in fact just damage cells and not help you extract the biopsied cells. So ideally, lasers are positioned in a place where they will be targeted at intercell junctions, so that it is also simultaneously associated with a pulling from the injection site. And then you need to make a clean cut. Alternately, if you have an embryo that has not hatched yet, it's a fully expanded embryo like we see in the figure, you can go in for a direct hatching followed by aspiration. However, as you can see in this embryo, it has detached from the entire zona. So if you keep on pulling it, there's a chance that the entire embryo might come out. So here is when you use a combination of both laser and the flick method. So this is basically how the flick method used, and it's also something that we use for completely hatched blastocysts, because we can just aspirate 3 to 4 cells or even up to 5 cells and then go in for a flick method. Now with flick method, there is one tip that I would like to suggest, is that you can go in for a lower magnification, basically because the laser objective is at a 40x magnification. You're looking at it very closely. And if you go in for a lower magnification, it helps to visualize and do the technique in a better way. And for those of you who have concerns about the use of laser in embryos, so laser should be used sparingly, as it is with any technique that we use. Overdoing anything is inevitably going to cause damage. But the impact of laser-assisted hatching has been assessed by quite a few people. And even the group that I have worked with, we have also looked at the impact of changes in embryo metabolism in response to laser-assisted hatching in both human embryos and mouse embryos. And I can assure you that we did not find any significant damage with laser when it is used properly. And most of the recent lasers have a low heat noise ratio. That means that the dispersion of heat area is not very large. It is focused to the laser point. So it is pretty good if you use it in a right way. So when we do use laser for biopsy, there are 3 different points where we can use it. Either we can do an early hatching, which is on day 3 or day 4, wait for the embryos to expand and hatch out. Or else do a same-day hatching method, or a simultaneous donor opening and trophectoderm retrieval in case you end up with an embryo that is grown late, or you are a center who has rented a laser, then the third option would be something that you can consider. So the best advantages of a trophectoderm biopsy is that we're looking at roughly 100 to 120 cells on day 5. And the tensile strength of the blastocyst is pretty good on day 5, and it can withstand the biopsy procedure. It has a lower degree of mosaicism as compared to day 3 embryos. The ICM does remain fully intact, and we will make sure that we are well away from the ICM during the procedure. And it does require a lab who has an optimal blastocyst rate and optimized their vitrification protocol, and a trained embryologist for it. If you look at the impact of trophectoderm biopsy, and this was a very good paper published in 2016 by a Chinese group who evaluated the outcomes with trophectoderm biopsies in grade A, B, C trophectoderm. So what they did find is if you biopsy 1 to 5 cells, irrespective of the trophectoderm grade, it does not impact implantation potential. And as you can see with the image below, the diagnostic failure rate is significantly low. It's up to 1 to 2% with 5 to 6 cells in the embryo biopsy. Coming to the most important part of biopsy, most of us are so focused on looking at biopsies that we forget about the tubing. And I feel personally that the tubing is the most challenging part of the biopsy. All your hard work in a beautiful biopsy can be lost in a matter of seconds. So this is where you need to be extremely, extremely careful. Tubing formulations differ from companies to companies. What I would suggest is to not mess around with tubing formulations and just use the solution that is provided by the genetics company, because A, it should match with our protocols, and B, is of course external contamination to the sampling. So it's usually consists of phosphate buffered saline of different molarities and supplements that we might use. Some of us use PVA, some of us don't. Some day 3 biopsy tubing solutions are calcium magnesium free. And also the tubing medium, the volume of the medium in the tubes should be restricted to a maximum of 5 microliter. This is mainly because we do not really remove the biopsies again once it is tubed and then use them for amplification. DNA amplification is directly done in the tube that you put the biopsy in. So you need to make sure that you do not load excessive amount of media into it, because it will dilute the final end concentration of the DNA. And something that is very important we need to consider is using a new stripper pipette for every single tubing. Under no circumstances can you reuse the same stripper. It will cause cross-contamination of DNA across embryos. And coming to the documentation part of it, it should be decided well in advance with the embryology team what they're going to label the embryos as. In case there are more than 2 patients on the same day for the biopsy, mixing of the labeling becomes always a risk. So in my personal opinion, I always use 2 different kits for 2 different patients. That makes sure that we do not mix up anything. Also, I usually prefer using initials of the husband and the wife as 2-letter code, followed by the embryo number. The dishes for biopsy should also be labeled with the patient name and the clinic ID. Of course, as any other procedure in the embryology lab, we cannot stress enough about double witnessing procedures. Biopsy cells should be washed a minimum of 2 to 4 times. Ideal wash numbers is 4. But what I would suggest is, in case you feel that the biopsy is very sticky, this happens in grade BB embryos, or if you're biopsying vitrified embryos, the biopsy material becomes extremely sticky, and it can stick to the base of the dish, it can stick to the stripper pipette, and you might lose it. So at any point of time, if you feel that you are about to lose the biopsy content, directly proceed for tubing. You can skip the steps. Another thing is the overlay of oil. Now, the beauty of overlaying with oil, it gives us visual clarity for embryo handling. But when it comes to tubing, ideally, we would not prefer oil layering if you're new to this technique, because if you tube oil along with the biopsy into the sample tube, that would interfere in DNA amplification. So ideally, that should be taken care of. As I said, a new pipette should be used for every single biopsy. If you feel that any cell has lysed, this is mainly for day 3 biopsies, or part of the sample has lysed, do not reuse even the biopsy needle. Everything has to be changed the minute you visualize any kind of cell lysis. Coming to negative controls are usually the washing medium and the tubing medium. So ideally, there should be at least a single negative control from the laboratory side. This provides an internal quality measure of the tubing conditions. If in ideal scenarios, I would prefer a tubing solution to be taken at least once at the beginning, once at the middle, and once at the end, if it's not too much trouble. If you are going in for a PGT-A or PGT-SR cycle, it is mandatory to give a negative control for every single biopsy tubings. So there comes a point of time when you can clearly see blastocyst biopsies. They remain as cell aggregates. These are ideal. We can easily go ahead and tube them. So if you can see in figure A, these are a bunch of cells that got dissociated when they were ejected from the biopsy needle. And here it becomes very difficult to decide what exactly you tube, because the risk of WGA failure becomes higher in such cases. So ideally, these cells are not very informative because you can hardly see one intact cell, which may not really be a trophectoderm cell. It could have been an extruded cells. In figure B, if you can see my arrow, it is pointed at a circular entity, which we would mistaken to be a biopsied cell, but no, it is a cytoplasmic aggregate. So when view biopsy, a part of the trophectoderm in the initial stages or somewhere in between, a certain part of them just come out, and they in the culture medium they will reassemble itself into a completely spherical structure, and these are cytoplasmic aggregates. They do not contain any DNA, and if you tube most of them, they would result in WGA failure. Coming to the tubing procedure as such, if you can see figure A, the tube is just left on the table. That is not at all ideal. It is not recommended because it can get contaminated very easily. And also, yeah, I will finish it quickly, sir. So you either can keep it at a 45-degree angle, or you can keep it on a tube holder. So there are a few times when the PGT reports might fail. This is ideally because of cell quality, or because of cell dissociation or cell lysis. Those are biopsy-related conditions. Tubing-related conditions is if you have been introduced any air bubble during tubing, and then the sample is frozen. This might cause the cells to lyse prematurely. This can be avoided by giving a quick spin and a short centrifugation, not a full centrifugation, a very quick spin will help in pelleting down the sample. Some quick tips that I would like to suggest quickly is always perform a trial on your laser before the biopsy on degenerated oocytes or embryos. Take at least 4 to 6 embryos for each blastocyst biopsy. Read through the reference material from your genetics lab and make sure you don't over dilute your sample. Rinse stripper tips with tubing solution before using each tubing, because this will help to avoid hydrophobicity in stripper pipettes. If you, of course, insert air bubble, quick spin, and avoid repeated laser starts, overstretching, and repeated scratching while flickering. The quicker the procedure, the better the outcome. So to conclude, I would like to stress on a few points. Be prepared, make sure your equipments are functional, select the right embryo. Blastocyst biopsy is the preferred option right now for PGT. The more you practice, the better. Make sure you visualize biopsy cells and identify them clearly. When in any kind of trouble, stop, wait for a minute, decide what to do next clearly, and then you can proceed. And counseling on the patient and transparency in the procedure is very important. Thank you so much.
Thank you so much, Dr. Fiona. That was an elaborate and in-depth discussion of how do we ensure we're doing the process right. The floor is open for questions. We would appreciate the audience type in the questions in the chat section. So Fiona, we've got one, Ms. Apeksha asking you a question. Do you suggest biopsy from an embryo with central pitting and many Acr clusters?
I think that we would be more focused on the quality of ICM and trophectoderm. Acr clusters don't necessarily mean that I cannot biopsy it, but of course it depends on your main embryologist and your clinician. Always get in touch with the clinician and explain to them that this is an embryo we are biopsying and the possible outcomes of it, and then you can proceed.
Wonderful. I think adding to it, I think there is no consensus on that. And
Yes.
I think this Acr clusters and central pitting is more seen in a cleavage stage biopsy, which I think we would strongly not recommend doing it. So I think we should be going with a blastocyst stage of biopsy. So there's another question which says, which number of stripper is ideal for tubing? I'm sure she's asking the diameter of the stripper, the size of the stripper.
Yes, you can use a 135. I think the smallest is the better. The reason we would
glass donating pipettes, what we have got is of 125 millimeter size.
Yes, we would avoid large diameter pipettes because that would mean that you would eject more tubing volume into the the sample tube.
Yeah, I think that's another important point. Even myself as a beginner, when we used to do this, we had this tendency of putting in a lot of the phosphate buffer saline into the PCR tube, and the genetics lab used to call us and say, no, that's too much of a volume, and sometimes there is a risk of no DNA being amplified. So try and keep the volume in between 1 to 2 microliters in your PCR tube. The next question they've asked is the best blastocyst stage. I'm hoping they're wanting to ask about day 5 versus day 6 or day 7. Shiri, I'm hoping that's the question you've asked. So Fiona, what is your take when we're talking about day 5 and day 6 and day 7 embryos?
Okay, so I think a biopsy until early day 6 should be okay. I'm not much in favor of day 7 embryos because they're too slow, and then the endometrium needs to be synced for the embryo transfer, and the chances of a failed implantation is higher in that case. And also a slow growing embryo means that something has gone wrong. I would definitely go for a day 5.5 to day 6 blastocyst biopsy at the max.
If you really review the literature out there, I think the question that's always that's posed to all of us was, would a day 6 embryo per se have a higher incidence of aneuploidy over a day 5, because day 6 also has a 24 hours of delay. I think so far there doesn't seem to be a significance between a day 5 or a day 6 blastocyst in terms of the aneuploidy and euploidy rates. Yes,
That's
day
right.
6 aneuploidy is very high. The possibility of having a euploid embryo, if at all you're getting a good grade blastocyst on day 7, I would recommend that it should be biopsied, because there's only a less than 10% chance of a day 7 blastocyst being euploid. So for some reason, your SOP says, or your clinician or patient wants the embryo to be left till day 7, which can be, but I think doing a blind transfer might not really give us the best outcome, because 90% of the times they are aneuploid. So there's another thing, day 7 blastocyst, there's enough literature to provide a reasonable live birth if euploidy is confirmed. Yes, there's some Mr. PCUs posted out. I totally agree with you. If it's a euploid embryo, either way, when it's a day 7, we are going to be freezing the embryo and not looking at a fresh embryo transfer. So if it's a euploid, you're putting back in a frozen embryo transfer cycle. It should give you the same outcome as a day 5 or a day 6 euploid embryo would give. So if you were getting an embryo on day 7 or you're culturing it, make it a point that you're biopsying it and only if it's euploid, you're transferring it. So if there
are few, Krishna,
there are few in
questions,
QA box.
in Q&A box. Please
Okay,
check it.
Krishna, can I ask a question?
yes, please.
Fiona, you mentioned about day 4 embryo biopsy. So can you elaborate it a little bit? And in
Sir,
which condition do you do day 4 classes?
I have not discussed day 4 biopsy. I was just discussing day 4 hatching. And day 4 biopsy is something that is recently coming up. Many people are going in for it. In my opinion, I'm still a little skeptical about it because of cell-fate determination, and you still can't visualize an ICM. And the cell-to-cell junctions are way more tighter at day 4. So it would be quite challenging for beginners. Maybe experienced embryologists can have a go at it.
Can I add something here?
Yes, ma'am, please.
I think George is an expert. He demonstrated day 4 embryo biopsy at ACE Chennai. I think maybe he can give us some idea on day 4 biopsy.
I think the technique itself is actually a lot more simpler than the blastocyst biopsy. I would say that it's even easier for people that are just starting training in ICSI to perform a day 4 biopsy. The cell compaction is being loosened by using calcium magnesium medium. Then it's a lot simpler to just expel the cells from either aspiration or just tapping the embryo. Yes, there is the question of whereas it might affect lineage and whether we're taking out cells that could raise the trifectoderm. Our data that we have been doing this approach throughout our PGT program shows that we have the same amount of blastulation as we would expect to get from the range of patients not having PGT. So therefore, blastulation is not affected. And our results are strongly indicating that pregnancy rates, live birth rates, and even safety data from those patients that have had babies born without technique show no increase in any abnormality so far. So even though it hasn't been tested in a randomized control study yet, so therefore we cannot safely say that that is a technique that definitely can be employed without risk. It can definitely be introduced as a method of, for example, if we want to standardize laboratory procedures and we want to do biopsies at a very specific day, on a day 5, you can test embryos that are behind on that day. If patients don't have many embryos available, you can consider biopsying embryos that show delayed development on day 5. So therefore, are in fact morulus or compacting embryos at that stage, because our data show that even those embryos that are delayed show that they can result in live birth. Of course, in a lower rate than what an expanded blastocyst would, but that is a substantial chance to not utilize, especially if the patient doesn't have many embryos available.
So George, can it also help day 4 biopsy in performing fresh ETs?
Absolutely, absolutely. That's the benefit of it. That's the beauty of it, that it bypasses the limitations of the day 3 biopsy in terms of ability to aspirate more than 1 or 2 cells at max, which limits the efficiency of the genetic analysis. With the day 4 biopsy, we can get a lot more cells. And if the genetic laboratory is within proximal location and can have the results generated within 24 hours, in our situation, that's what we had, a genetic lab on site being able to produce those results within 24 hours. We were all for day 5 transfer on the concurrent cycle. Great. So therefore avoiding the FET cycle altogether and using it only for supernumerary embryos following the analysis.
Great. Krishna, you can take.
Yeah. I think that a couple of more. We've got another 5 minutes to take questions, right? Because there's some 5 questions. So one of the question is by Mr. Mohammed is, I'm a beginner for ICSI. How soon can I start doing the biopsy procedures? Fiona, if you would want to help us answer that question.
I would ideally say, in fact, even according to SHA guidelines, you should be able to successfully practice on at least 50 embryos, embryo biopsy on 50 embryos But in India, we preferably use somebody who has done at least 1,000 ICSIs.
Wonderful.
And they should be good with the manipulator. So that's that.
The next question is, should we be changing the biopsy needles for every embryo that we are biopsying?
Ideally, I would say yes, but in a price-constrained market like India, we do try to use one needle for more than one embryo. But as I said, if you feel that the cells are sticky, even if you feel a cell has lysed inside your biopsy needle, it's an indication for you to change the needle the very next for the very next embryo. In case you're going to use the same needle for the second embryo, you need to rinse it thoroughly, provided, of course, as I said before, you should not have lysed cells in the biopsy pipette.
Right. So the next question is, would you recommend rebiopsy of embryos that didn't give you a conclusive report?
I would not really recommend it if it's already vitrified, because already a dual freeze-thaw cycle is going to reduce your implantation potential. So in that case, if you are going to vitrify the embryo, thaw it, second biopsy, again vitrify, wait for the report, again thaw, that means 3 cycles. That's a bad idea. I would rather take a chance by transferring it. Of course, if you're going in for a day 3 or day 4 and it's a fresh cycle transfer, then it's something that you can consider, yes.
If at all you're attempting a day 4 biopsy, how many cells removal is recommended?
I think George is the best person to address this. Could you please?
So George, if you're talking about modulus,
it would depend on the number of cells within the morula. So at least 4 cells would be adequately and easily obtained. And try to not get more than 6 cells, I would say, in a 32-cell embryo, just because we try to still have a substantial number of cells to continue developing. But with 4 cells, usually, the affinity of the genetics can still be sustained. There's enough cells there to give a positive amplification outcome and a good result.
All right. Thank you so much, George, for that. But you know, a day 3 or day 5 is all the same, right, George? It's just about exposing them to a calcium magnesium free buffer and pulling out blastomeres.
It's exactly the same, precisely. So the technique itself, actually on the day 4 is the incision on the zona is much smaller. Just have in mind that the cell size decreases from a day 3 to a day 4 as well. So therefore, they're much easier to obtain after exposing them to calcium magnesium free media. But the technique itself is exactly the same.
Wonderful. Thank you so much, George, for that. One last question, Fiona, from my end. You know, there's been this little concept of reducing the laser shots. You know, in that little stress when we are pulling the tissue out, sometimes manually the tissue isn't coming out, and you tend to hit multiple laser shots. You know, there isn't a consensus or a clear-cut idea as to how many laser shots is safe. If you could just throw some light on that, please.
Yes, of course, sir. It depends upon the usage and the type of laser you're using. So every laser has their own specifications. So when you buy the laser company itself will give you the biological standards by which they have validated the lasers. That's one thing. Ideally, when there is a certain point when you decide, yes, this is too much. And I think it's a person to person, it's a subjective call when you need to take a call and stop. Of course, blindly hitting laser on the embryo when it's not helping, it just doesn't make sense. So I would prefer 3 to 4 shots. And if you can't see anything happening, either proceed for a little bit more stretch and a flick technique. Immediately shift gears, because we can't keep shooting 15, 16 shots at the embryo. That is not a good idea.
Would it increase the aneuploidy, or George or Fiona, would excessive usage of laser increase the aneuploidy in the embryo by any chance?
I do not think so, because aneuploidy and the impact caused by the laser are 2 different concepts. I would think that it would cause DNA fragmentation as opposed to whole chromosome aneuploidies. fragmented DNA is possible.
Would it cause a higher incidence of no DNA amplification if you use excessive laser because the cell is
Yes, that is entirely possible. If you are continuously shooting at cells, you would probably be disintegrating the DNA in that cell, and it would be more susceptible to lysis. So yes, excessive use, as I said, is going to be damaging. This is the reason it also
DNA in those cells is very likely to be damaged. So getting amplification may be difficult.
That's right. And it also increases the mosaicism results because mainly because it interferes in the noise data of NGS. So that can also contribute to mosaicism calculation. That's why.
I think we have to stop now. Sorry
Thank
to interrupt
so
you.
And
thank you.
We will start for next lecture. Sanketh,
thank
please.
you, everyone.
Thank you so much.
Yes.
Thank you so much.
Thank you so much, Dr. Fiona and Dr. Krishna, for taking up all the questions. And I hope all the audience has, at least for those who are beginning to do biopsy and all, there were a lot of tips and tricks to practice the biopsy. And without taking much time, I would like to ask Dr. Akash to introduce our next moderator.
Hello everyone, it's a wonderful Q&A going on and there's no end to it. Like we just want to keep listening and listening, but because of time restraint, we'll quickly move forward to our next topic. And I have the honor to introduce our next moderator, Sujatha ma'am. She's the head of the embryology for NOVA IVF. Dr. Sanketh, if you can share the screen, please.
Dr. Yeah, 1 second.
Ma'am is heading the embryology department at the NOVA IVF Fertility. She has done her PhD in biochemistry and molecular biology from the University of Mysore. She's a certified embryology lab director by American Board of Bioanalysts and held as a position of lab director in various hospitals like British Hospital, Abu Dhabi, Kraft Hospital. And ma'am is presently the secretary for ACE as well. Over to you, ma'am.
Thank you, Dr. Akash. Thank you, iHERA team, for this opportunity. That was a very impressive talk by Fiona. I really enjoyed listening to that. Now, the next topic is on mosaicism. See, the idea of introducing PGTA is to identify normal embryos, that's embryos with normal chromosome complement. However, during the process, a new phenomenon was unveiled, and that is mosaicism, where you have normal and abnormal chromosome complement cell lineages present in the same embryo. And that actually causes a lot of dilemma, whether you can transfer these embryos or not. There is even a school of thought where they say that until this mosaicism is sorted out, you shouldn't even be offering a PGTA or PGS to the patient. So to address this very important topic, we have with us Dr. George Liperis. He is a well-known figure in the Indian embryology scene. As I had mentioned earlier, he was one of the experts at the ACE 2019 conference in Chennai. He demonstrated a lot of, he was, the lead faculty in our embryo biopsy workshop. So Dr. George is currently the Deputy Scientific Director at WestMed Fertility Center, and he's also the Senior Lecturer at the University of Sydney. Over to you, George.
Thank you, Dr. Sujatha. Thank you to iHERA for inviting me to give this presentation on mosaicism. Thank you for the nice introduction that you have done. Thank you also to the conveners and the coordinators for putting out such a nice program. So this talk is going to focus on mosaicism, which is the unexpected culprit. So what I'm going to cover in this presentation is first give an overall introduction of PGTA, and then talk a little bit about mosaicism and how we came to encounter it, and how often it is that we see mosaicism with the techniques we use. And then to move on how mosaicism is managed at the moment in order to give a conclusion. So what is PGTA? Of course, everyone involved in this webinar is involved or starting to involve in biopsies. So pre-implantation genetic testing for aneuploidy. or PGTA as it's now been termed, is used clinically in over 20 years now. So it is used to identify embryos that have an aneuploidy, a new arising aneuploidy from the combination of the egg and sperm. And that includes subchromosomal deletions, duplications, and all of those in couples that have normal karyotypes. So PGTA is driven by the belief that we know that the embryos have high degrees of aneuploidy, and we know that this aneuploidy increases with advanced maternal age. So therefore, we know that unemployed embryos do not implant always. Therefore, the hypothesis is that if we eliminate those unemployed embryos, the embryos that we transfer should give us higher implantation and pregnancy, and therefore lower miscarriage rates. And this is always driven by this nice graph that I'm sure everyone has seen it many times from the US CDC SART data that shows that the rise of aneuploidy is coincided with the rise of miscarriages as the maternal age increases, and this leads to a significant drop in the live birth rate. So who do we guide towards having PGT-A? So there is the ESHRE PGT Consortium for Best Practice Guidelines, and a few categories of people that are suitable for having PGT-A include patients that have had are of advanced maternal age of more than 36 years, but each center uses different determination of that age factor. Recurrent implantation failure of more than 3 embryo transfers with high quality embryos, or the transfer of more than 10 embryos in multiple cycles. And again, that is determined by each center. And that the implantation failure is determined by the absence of the sac by ultrasound at 5 weeks. Also recurrent miscarriages, having 3 or more miscarriages. And in patients where recurrent miscarriage has been seen, there is a high chance of conceiving naturally. So where does mosaicism fit in the scheme of things? First of all, we need to understand what mosaicism is. So mosaicism is the presence of 2 or more cell lines that have different genetic makeup. And there is a few different types of mosaicism. We have mosaicism in individuals that have more than 1 cell line throughout their bodies. We have mosaic embryos, which is what we're going to focus on today, that consists of cells with different chromosomal constitution. And we have confined placental mosaicism, or CPC, in which the placenta has different chromosomal constitution to the developing embryo. Therefore, the developing embryo being euploid, but only parts or the placenta being aneuploid. So how does it occur? Mosaicism occurs from mitotic events and errors during those mitotic events during post-zygotic development after fertilization. And usually the reason for that is sister chromatid malsegregations, but there's other reasons as well. So if a DNA copy that contains a mistake or an occasion where the DNA splits unevenly, the result is cells that have different genetic constitution. And in some cases, these cells might not develop, but if they do develop and continue dividing, the result is what we call mosaicism. So where did this mosaicism arise? There was a letter back in 2015, a letter to New England Journal, that reported the delivery of 6 healthy babies from a small series. It was a small study of 18 women in whom embryo screening found no normal embryos following analysis. So the transfer of mosaic embryos was made available, and when those women did not have a normal embryo, and that resulted in 6 live births of a singleton infant at term. So this study showed for the first time that mosaic embryos can develop and give us babies. And this had implications for women that don't have any normal embryos, but only have mosaic embryos. So how often do we see mosaicism? So given the fact that the aneuploidy testing relies on the chromosomal constitution of the biopsied cells, and we consider those to be representative of the whole embryo. So the presence of the mosaicism, however, can potentially lead to incorrect classification and therefore undermining the principal strategy of improved embryo selection. So we can be counteracting on what we're trying to do. So the traditional method for modern PGT, following the early stages of fish, has been the usage of comparative genome hybridization array, in which we have the sample DNA and a controlled sample DNA that are labeled with different dyes. And then those samples are being mixed and hybridized on a microarray that contains a lot of olignucleotide probes, and then is washed away. So then the signals from the fluorescent samples are detected by red and green, and then by using the scanner and then using the software, those are computed, and then we get a report of gains or losses in the test DNA. This technology has now evolved. So majority of genetic labs will now be using what we call next generation sequencing, which involves a little bit of different technique. And this is another example. There is a few more options out there. The first step, it involves what we call the library preparation, in which the DNA from the amplified cells is being first fragmented and then ligated with specific adapters. Then the library is loaded into a flow cells, and again there is a hybridization of the fragments to the cell surface, and then the bound fragments are amplified into a cluster through amplification. Then this is followed by sequencing, and where again fluorescent labels are being used, followed by alignment and data analysis that are being used to identify additions or removals using bioinformatics software. So this is a more sensitive technology. So surely by using this technology, we should be able to eradicate uncertainty for embryo selection and make this technique result in better results, right? Or maybe not. So this technology has allowed for a higher proportion of mosaic embryos to be detected following the biopsy. So the true prevalence of mosaicism is very difficult to be identified from a single trophectoderm biopsy. And there's a few reasons for that. First of all, the proportions of the biopsied samples are not representative of the embryo. As we have seen in the previous talk by Dr. Fiona, we only aspirate a few cells from that trophectoderm. Usually that is in the range of 5 or 10 cells. Also, the distribution of abnormal cells within the biopsy trophectoderm is not always uniform and cannot therefore reflect is that the true chromosomal constitution of the blastocyst, what we have seen in that tube that we have loaded. Does the biopsy sample contain cells from each of the cell lines that is represented in the whole embryo? And the quantity of the DNA is also important, with detection not feasible in poor quality samples. As we did discuss earlier, multiple shots of laser might affect the quality of the DNA. And here we can see one example of that in this nice paper that was published a few years back. So we can see this is the same embryo, and we can see that on the above, there is a high level of mosaicism. We can see that the 5 cells that have been biopsied and aspirated, from the 5, 2 were diploid. So there's a 60% unemployed cells in that mosaic embryo. Whereas in the bottom embryo, if we take a different distribution of cells, we can see that only 1 cell that was unemployed, therefore a 20% unemployed for mosaic. So the prevalence of mosaicism in trophectoderm biopsies has been reported over a wide range and with high variation in different centers. So it has not been standardized throughout. And also, more importantly, and what avoids a certain consensus to be reached, is that each genetic laboratory has their own guidelines in terms of reporting mosaics. So where is that line drawn? Each center will have its own guidelines. A rough idea is that if there is less than 30% unemployed cells within the amplified samples, it's considered normal. Anywhere between 30 and 70 to be considered mosaic, and anything more than 70% of the cells consisting of unemployed cell lines to be considered unemployed. But these are just an example in terms of what some of the labs might be following. The recently published START trial that evaluated PGTA with NGS reported mosaicism in about 17% of all blastocysts analyzed. So what does that mean? It means that for 6 embryos, as we can see in the picture below, 1 is mosaic. So what if the other embryos are all unemployed? What happens to that embryo? So that is a significant embryo, and as we can see, that could sometimes be the best available embryo in terms of morphology, and sometimes the only embryo available in terms of not being 100% unemployed. So how do we manage mosaicism? Should all mosaic embryos be classified as clinically unsuitable? That would be a safe practice for some laboratories if they don't want to undertake any risk. However, this conservative approach will reduce the chances of pregnancy. Therefore, a more realistic approach is the definition of a third diagnostic category to be added to euploid and unemployed embryos. The rise of the mosaics. So what about mosaics? What happens to them? Mosaic blastocysts appear to be associated with higher rates of miscarriages than euploid embryos when we transfer them back. And the studies also show that there is lower rates of implantation and live birth following mosaic transfers. Embryos with single mosaic segmental aneuploidy, as well as mosaic embryos from women that are young, tend to have better results. So this is not universal throughout all age groups. However, transfer of mosaic embryos that have more than 50% chromosomally abnormal cells show a relatively low live birth, and those that have an unemployed rate of less than 50% demonstrate a high live birth rate. So there is a range where results might be better in terms of the mosaic levels that are detected. However, we have to know and understand that always a euploid embryo implantation potential is higher than that of a mosaic embryo. So therefore, euploid embryos should be prioritized over mosaics when they are available within the cohort of samples that have been biopsied. But how can it be that an embryo that formerly discarded as abnormal can actually develop into a viable pregnancy? There is this thing called self-correction that has been the natural apoptosis of abnormal cells. So this is what the embryos employ. The mosaicism introvector themselves might be a normal feature of early embryonic development, as the incidence of mosaicism decreases with gestational age. As we have seen in the START trial, is about 17%, but most labs will report around and less than 30% in biopsied embryos. When we take CVS samples in prenatal testing at 12 weeks of gestation, this goes down to 2%. So we can see that even though we detect a high rate of those mosaics, that is being a few months later on following implantation, that is being dropped to 2%. And then that is even lower in amniocentesis when is being done at 16 weeks of gestation. And we see that the rate of mosaicism drops as low as less than 0.3%. So mosaicism observed introfectally in biopsies is not observed in chorionic villus sampling or NIPT samples. But more importantly, more than 800 mosaic embryo transfers reported today that had matching amniocentesis, because after transferring mosaics, the patients are guided towards having an amnio to verify the constitution of the embryo. So the matching amniocentesis And in the overwhelming majority of those cases, they were normal. If an abnormality was reported, this was an independent to mosaicism observed during the PGTA. So therefore, a different abnormality altogether. So there are live births following the transfer of mosaic blastocysts that have normal karyotypes. Only one study has shown otherwise so far in the literature. This is a single case report from Turkey that has described the birth of a baby that has been reported with mosaicism, and then that was following a transfer of an embryo with a non-mosaicism. So that was a 39-year-old patient with a poor prognosis and poor ovarian reserve. There was only one embryo available, and that embryo was tested. That embryo had a 35% level of mosaicism for monosomy for chromosome 2, and that baby was born having a 2% mosaicism for monosomy 2. So that was the first report in over 500 studies of mosaicism that shows that mosaicism can be persistent and be developed in the baby and in the and following the transfer of a mosaic embryo. However, these authors do not advise towards not transferring mosaic embryos, but rather advise towards prenatal monitoring and diagnosis by early amniocentesis to verify the findings of the PGTA. There has also been introduced suggested recommendations to assist in the prioritization of mosaic embryos considered for transfer, as we can see in this paper that was published 2 years ago. So first, we considered the embryos that are more suitable to be those with low level of mosaicism, therefore lowering the risk. And if those are not available or after they have been used, then move on to specific chromosomes involved and current knowledge about whether they are syndromic and about their mosaic levels that can cause those syndromes. However, we have to look beyond mosaicism. There is a further evidence against the use of PGTA in poor prognosis patients. In the study that is mentioned above, published 6 years ago by Glacier, there were 8 couples that were identified for potential embryo transfer of monosomic embryos. 5 chose to undergo transfer. 3 conceived and delivered healthy chromosomal normal offspring. And we can see here the monosomy is in place and the outcome. So again, what is the issue? So it could be that the embryo allocates poor cells to the trafectoderm while maintaining the best for the inner cell mass. That's one theory. It is possible that the genetic laboratory can only analyze the cells obtained in the biopsied cells and not the embryo itself. So therefore, those embryos could very well be mosaics in which only the abnormal cell line was obtained. And it also could be the self-correction of the embryo. So aneuploid cells might become diluted to the point of being negligible. In cases where those cells are confined to the trophectoderm and persist through development, we know that the potential consequence is what we called before the confined placental mosaicism. And human placentas often contain islands of aneuploid cells and are believed to be able to adapt to those chromosomal abnormalities much more than the fetal tissues. And we do know that majority of CPM cases result in healthy babies. Depending, however, on the aneuploidy involved and the percent of abnormal cells, the condition can result in miscarriage. So sometimes those embryos can result in miscarriage. Is that enough reason for not offering that to the patient? In summary, we all go into this field knowing that we have to first do no harm, primum non nocere. Excluding mosaic embryos appears to conflict the goal of achieving a pregnancy and live birth in some patients. So those patients have already been committed to having the genetic biopsy. This is the result. This is the embryo. Is their embryo? Is their chance of having a baby? Are we to take that chance away from them. However, using those embryos takes a lot of work. All patients must be informed and consented about the risks and the possibilities from transferring those mosaic embryos. So use of genetic counselors is highly indicated in order to proceed with using those embryos. And the transfer of mosaic monosomy embryos must still be approached carefully, and pregnancies must be followed up by prenatal testing and close monitoring of those pregnancies. In conclusion, careful consideration has to be tailored to each couple before making the decision to offer the transfer of those mosaic embryos. Thank you very much for listening.
Thank you very much, Dr. George. That was a lucid presentation. You covered everything. Let me see.
Thank you, Sujatha.
We have a question here. It's from Dr. Rita. Good evening, Dr. Rita. So her question is, some centers have started doing PGT-A routinely for all cases. She is asking for your view on this.
This is a lengthy aspect to go into in terms of whether PGT-A should be utilized. And as we can see from the mosaicism levels and all the healthy babies that have been born following transfer of aneuploid cell lines, the biopsies itself, in terms of detecting the aneuploidies, are not foolproof. Therefore, there is a chance that we might be not utilizing embryos that can in fact result in healthy live births. Of course, there are indications, and those indications are good to be used. So each center should evaluate the pros and the cons of utilizing PGT, and in terms of which patients would be more favorable and needing to have this kind of process, and whether they would benefit in such.
Dr. Rita has also asked a second question where she has said, like, in older women in whom often we get fewer blastocysts, what is the role of PGT-A?
Sorry, I didn't get the question, Dr.
She's saying, is there any point in doing PGT-A in elderly women where we get very few blastocysts?
Yes, good question. If, for example, the patient only has 1 or 2 embryos available, they have to consider is tailored to each couple. If they understand the limitations of the technology, and if they understand the consequences of transferring an embryo that could potentially lead to an abnormality, then it's up to the patient to make that informed choice for themselves. I would say that would not be about driving the patients towards a decision. It's more of informing them about the technology, the limitations of the technology, the pros and the cons of using this tailored to themselves. If, for example, a patient has committed to having a biopsy and only has, after growing their embryos, only 1 blastocyst, even though, let's say, starts with a good number, but those numbers drop, or the developmental capacity is low, and we only have 1 embryo that is suitable to be biopsied. If the patient is happy to transfer it back, if the embryo implants, if it bypasses all those stops that can lead, and some of those might be aneuploidies that don't lead to implantation, don't lead to early pregnancy termination, and we go through the stage that we have a fetus that can be followed up by CVS and amniocentesis, then we can therefore test those, even by NIPT, to define whether that fetus is abnormal. So if that patient is happy with that risk going forward, because have in mind that those patients have started and wanted to be sure about the embryo that they're having back. So they want to be sure that their embryo doesn't have an abnormality. It could be a patient that has had recurrent miscarriages and doesn't want to go through any miscarriages. Again, it could be a patient that for religious purposes is not in favor of termination of pregnancy. So again, it all depends on individual circumstances.
So there is another question from Dr. Indu, where she has asked, is amniocentesis mandatory for all euploid embryo transferred pregnancy?
I wouldn't think that amniocentesis would be recommended by the majority of doctors following transfer of euploid transfers. Usually, non-invasive methods are suggested. For example, NIPT, that is non-invasive prenatal testing, can be done relevantly early in the pregnancy to verify for a few abnormalities that are associated with trisomies compatible with live birth. Because the majority of aneuploids will lead to monosomies or lethal trisomies. Therefore, a few of those abnormalities can be picked up relevantly easily with NIPT. So unless there is strong indication based on ultrasounds that guide towards the need for amniocentesis following the transfer of a euploid embryo, I don't think that it is recommended in the literature or by any clinics to be followed up by amnio.
George, I have a question here, maybe a little bit out of context, but I would like to know, is there any correlation between the laboratory condition or the culture condition and the incidence of aneuploidy? Because there was a paper which was published in Fertility Sterility a few years ago where they said like aneuploidy levels were higher in one particular center. So does it have something to do with the culture condition? What is your opinion or experience on that?
I wouldn't be able to answer that question, Sujatha, as I know that in our laboratory, we use very standardized conditions in terms of everything being standardized. And I would recommend that every laboratory does the same before they embark on starting a genetics program. So unless everything is set, there is in terms of quality in the laboratory, instead of establishing good vitrification, good blastulation, and good air control of the laboratory, I don't think that is suitable for any of those labs to embark on genetic testing and biopsies. So if the conditions are not right, therefore it opens questions of whether the personnel is up to proper training, all the clean techniques are being followed. So if the environment is not suitable, then how can we assure that there's no contamination in the samples to begin with? So contamination can be a big issue in those, and that could very well be a reason why that paper might have reported. I'm not familiar with it, so I cannot really say for sure.
Thank you, George. I think we'll take the last two questions. One is from Dr. Vijay Mangoli. He has asked, from a 6 to 8 cell embryo, how many blastomeres should be taken out to rule out mosaicism?
So the difficulty with the day 3 biopsy, and this is why it has been majorly abandoned by the majority of centers, is that if the embryo is 6 cells, no more than 1 cell can be taken. So if we take 1 cell, we can understand that we will never detect mosaicism. We will just detect euploid or aneuploid, and we could be incorrect in what we have detected. If only the embryo is an 8 cell, then safely we can get 2 cells out of the embryo without jeopardizing its developmental capacity to the blastocyst stage. So again, by taking 2 cells, there is a higher indication of detecting mosaicism, because that's the quarter of an embryo. But again, it has to do with the distribution of the cells. we cannot rule out that mosaicism is still not present in those cells, even if that's the 2 cells that we have taken. So I don't think any labs take more than 2 cells from a day 3 embryo.
So the last question from Dr. Rita again. So she's asking, in recurrent implantation failure, what would be, apart from aneuploidy, like there can also be endometrial factor, isn't it? So what would be the incidence of it? And she's asked, like, is the incidence of aneuploidy higher in couple with severe teratospermia? Is there any correlation? And she says, like, this information would help in counseling patients. Your opinion on that?
So in recurrent miscarriage, we know that in fact a lot of those miscarriages, especially at these early stages of pregnancy, can be due to aneuploidy factors. So that's one factor to rule that out, is by doing the genetic testing for aneuploidy. Of course, that doesn't mean that the reason for it is the genetic. However, we rule one of the possible indications for the miscarriages by having the genetic analysis done. But Dr. Rido is correct. There could be other indications for miscarriages, and therefore all of those should be looked at by the fertility specialist that has the care of the patients prior to embarking on their cycles. So in terms of the sperm, there is not a lot we can do. When the samples, the purpose of the lab is to basically select the best available sperm by meeting all the parameters and in terms of morphology. From there on, usually the sperm is associated with microdeletions in the AZF region. So therefore, those are the ones that could be passed on to the next generation. I wouldn't think that the sperm quality will indicate towards a higher level of mosaicism observed, or unless I'm not aware of any recent studies that have shown otherwise.
Thank you, George, for that wonderful presentation and for answering all the questions. And over to iHERA team.
Thank you, Dr. Sujatha. Pleasure.
Thank you so much, Dr. George and Dr. Sujatha, ma'am. So taking forward the session, I'll be introducing the next moderator. Dr. Rashmi Sharma. So it gives me pleasure to introduce our next moderator, Dr. Rashmi Sharma. Currently, she is working as a director at Oregon Fertility and IVF New Delhi, and she obtained her MBBS and MD from BHU. She is a DNB, MNAMS, and FICOG, and Diploma IVF and Reproductive Medicine from Germany. She's a joint editor for Indian Fertility Society 2022 to 2022, and former HOD at Moolchand and Max Hospital, New Delhi, and recipient of CS Dawn Award for Best Paper Presentation for her work on IVF and ICSI with genital tuberculosis at All India Congress of Obs and Gyn, and recipient of Hall of Fame and Best IVF Center in North India, awarded by Economic Times at National Fertility Awards 2019. So she is the recipient of Best IFS Executive at 40 Vision 2018 Kochi, and authored various chapters in infertility books of Tepu, and many national and international papers have been presented by her, and also she holds a lot of publications. So over to you, ma'am. Hello, ma'am.
Dr. Rashmi.
Sorry, I'll unmute myself. Yeah. So it's my pleasure to welcome Dr. Sheila Johel for the next lecture. Dr. Sheila Johel is a lead laboratory genetic counselor at Cooper Genomics, and she counsels patients seeking pre-implantation genetic testing. She came to Cooper Genomics after 9.5 years at Metro Health Medical Center in Cleveland, Ohio, where she provided prenatal, general, and cardiovascular genetic counseling. Master's degree in medical and molecular genetics with a focus in genetic counseling from Indiana University, Purdue University, Indianapolis in 2006. Bachelor of Science in Biology, and also a Bachelor in Arts and Psychology from Kent State University. That's really nice to have a Bachelor in Arts as well, along with the science degree. And she has a specific interest in disorders of hemoglobin, CFTR related infertility, and is passionate about educating genetic counseling students. She currently serves as a co-chair of the OAGC Web Design Subcommittee. So welcome, Dr. Sheila Johel, and over to you.
Thank you. Can everybody hear me okay? I want to make sure.
Yes, we can hear you, Dr. Sheila.
Okay, perfect. I'm so happy to be here. Thank you for thinking of me. It's morning where I am, so I was going to say good morning, but maybe just good day instead. I'm going to pull the screen up. I really enjoyed the talk about mosaicism, so thank you for inviting me. Okay. So I'm really happy to get to talk to everybody about a topic that's really important to me, and that is the genetic evaluation and testing and counseling of patients who are seeking IVF. I think this is a really important topic that we probably don't talk enough about. And for those who are familiar with it, I think repeating it never hurts either. So I really just want to walk through some of the more common genetic evaluations that you might consider for patients who are coming to you to seek IVF services, and why those might be important and how those might be helpful for the patients on their IVF journey. And then talk a little bit about how genetic counseling and genetic counselors can really play a role in IVF clinics and providing those services to patients. So for me, what I like most about being in this space is that almost every patient I talk to is in a preconception period. And before I came to my current role, that wasn't always the case. A lot of the patients that I worked with were already pregnant. And as most of the people in this audience know, when someone is already pregnant, their reproductive options then become quite limited. And so when someone is not pregnant, that's really the ideal time for genetic counseling and any evaluation that might be appropriate when we're thinking about assessing for reproductive risk, because patients who aren't pregnant have the most options available to them about what to do. And so I think it's really important to start with a really hot topic in the reproductive genetic space, and that is, besides mosaicism and PGTA, is the use of carrier screening. So, carrier screening in general is not a new concept. It's something that's been around for decades. In the United States, it started in the 1970s. And this is before we had even a DNA-based test of any kind to use. This was well before genetic screening was really available. And in the beginning, carrier screening in the United States was really focused at specific patient populations who were known to have an increased incidence of a certain disease. And the two examples of these carrier screening protocols were for patients who are of Ashkenazi Jewish descent, where they were screening for Tay-Sachs disease carrier status by enzyme, and then those who had African American descent were being screened for sickle cell by a sickle solubility test. And both of those things are still available for use today, but they really have gone by the wayside as DNA-based testing has come to the forefront. But we really didn't have any ability to do DNA-based carrier screening until 1997. That's when the first DNA-based carrier screening became available, and that was for cystic fibrosis. And then there was quite a lag, actually, in terms of carrier screening and its implementation. For many years, cystic fibrosis remained really the only DNA-based carrier screen that was offered or talked about. But since the early 2000s, this idea of expanded carrier screening has really taken off. And the reason that expanded carrier screening has really taken off is because what we're learning now is that genetic diseases that were initially thought to occur in only one population actually occur in all populations. Perhaps they occur with different frequencies. There really isn't a disease that's localized to one specific group of people. What we're also learning through the use of expanded carrier screening is that conditions that we used to think were rare maybe aren't as rare as we thought. We're seeing higher carrier frequencies, we're seeing higher disease frequencies, we're seeing different spectrum of diseases. And all of these things have led to this thought that perhaps an ethnicity-based approach is too limited. That maybe we're not screening for enough, maybe we are taking away some patient autonomy by saying they can only be tested for a couple of conditions, but you can certainly take either approach. And to go back to ethnicity-based for just a second, this is probably what most people are familiar with. This is focusing your screening on disorders that are known to have a high disease prevalence in a certain population. So in people who have European Caucasian background, that would be something like cystic fibrosis. For patients who have Asian background, that would be something like the thalassemias, particularly beta thalassemia. But as I said, we all know that anybody can really be a carrier of anything. And I thought it was really interesting when I was getting ready for this talk that it wasn't very long ago, just last year, that a group in India published a pilot study on carrier screening in a general Indian population. And I don't think there was anything about this study that was groundbreaking, except that I think it did drive home a couple of points that have been tossed around in the carrier screening community as reasons for doing carrier screening. But this really just put some data behind that. So this was a paper done, as I said, in 2020 by Singh et al. What they did was they did an expanded carrier screening panel of 88 conditions, 88 genes for 200 individuals. Of those 200 individuals, there were 88 couples. And 52 out of the 200 people were identified to be carriers. So that was about a 25% carrier rate. Now, they didn't find any carrier couples. That's not so unusual with a small sample size. But what was really interesting is that the carrier frequency for conditions that are really thought traditionally to be more common in European descent, like non-syndromic hearing loss, cystic fibrosis, Pompe disease, which is also called glycogen storage disease type 2, all of those things had higher carrier findings in the Indian population than previously reported or expected. And not surprisingly, the pathogenic variants that we describe in the European population were not really what was identified in the patients that are from India. And I think all this really did was just sort of drive home the point that the carrier screening of the past, where we're targeting things that have high prevalences, where we're doing genotype panels rather than sequencing, you're missing a lot of carriers and you're missing a lot of potential to identify couples at risk to have an affected child. And as I mentioned, the preconception point is really the time at which you want this screening done, because if you do identify a female carrier of an X-linked disease, or if you identify a carrier couple of an autosomal recessive disease, then they have options. And that might be pre-implantation genetic testing. There may be other options available to them based on their resources and their religious beliefs, but they have the most decision-making capacity before they conceive a pregnancy. So the other genetic test that I think is important to at least think about with patients is karyotype. So we've spent a lot of time talking about PGTA and screening for chromosome abnormalities and how that can be helpful and how there are pitfalls to that. But chromosome translocations, chromosome aberrations, they are very common. As you can see here, so a reciprocal translocation occurs in about 1 in 500 people. A Robertsonian translocation occurs in about 1 in 1,000 people. And you can carry one of those rearrangements if you're male, if you're female. Sometimes we find that both members of a couple have a chromosome translocation. And I think what's really important with a karyotype, and the reason that it's in my talk as something to think about with patients, is that there may or may not be a suspicious history. So, I think we're all aware of the red flags in a history that might clue us in that a translocation might be present, right? Like a recurrent pregnancy loss history, perhaps a recurrent implantation failure of untested embryos, perhaps a family history of, more people than you would expect with pregnancy loss or birth defects or intellectual disability. The other thing that we see in our setting in the PGT area, in the PGT world, is that there are some patients who are identified to have a translocation after they have had PGTA, and the laboratory finds these recurrent reciprocal derivatives on PGTA. But a lot of patients don't have that history, and maybe it's because they have a small family, maybe it's because they're adopted, maybe it's because no one else has experienced a pregnancy loss. Maybe they haven't experienced a pregnancy loss yet because they haven't been trying for very long. And so if we limit who we're testing to someone with a suspicious history, we may very well be missing patients that have these rearrangements. And a lot of people say, well, we don't have the resources to karyotype everybody. That's not indicated. How are we going to pay for that? All of those things are very valid. My only point in saying we need to think about this is that the presence of a structural rearrangement really does impact the couple's likelihood of producing a euploid embryo. And when we're in the setting of patients who are seeking IVF services, and there is a question of, do we do PGT, do we not do PGT, knowing if a structural rearrangement is present is actually really important, and it may help with decision making. If you have a patient who has not had a karyotype, you don't know their chromosome constitution, they're not doing PGTA, you are certainly going to end up almost certainly with more failed transfers and more miscarriages, because they're going to produce more embryos that are aneuploid. And not looking for an aneuploidy in an embryo doesn't mean that one is not there. And if you have a couple where you've got a known translocation or other structural rearrangement that's going to predispose to aneuploid embryos, if that couple is going to embark on PGT, that is, again, really important information for two reasons. One is it's going to change the number of samples we expect to be euploid, right? So if we're quoting, let's say, a 32-year-old patient, a risk of aneuploidy based on age, every lab has a little bit of a different data point, but it's about 50% euploid rate. But if you've got a couple that, the female patient is 32, but there's a translocation present, that euploid rate drops significantly. Depending on the translocation, it's going to be somewhere between 20 and 30%. And that's a big number in terms of what to expect for outcomes. The other thing that's really important is that if there is a structural rearrangement like a translocation, you have to make sure you talk to the PGT lab first to make sure that unbalanced forms of that translocation are identifiable on PGT, right? Because all PGT platforms have different resolutions. And if you have a rearrangement that results in very small derivative chromosomes, PGT may not identify that, which means there may be embryos identified as euploid when in fact they have an unbalanced translocation, which again is really important for patients in decision making. And so while there are no formal guidelines to say everybody who's doing IVF should have a karyotype, I think it's something we should think about and discuss in context of the patient's history, what their goals are they thinking about PGT? I think this is really something that we need to just be aware of and make sure that we are counseling patients about the availability. And like with everything, what's the benefit of this? What's the limitation? What's the likelihood we're going to find something? So part of the genetic evaluation for patients who are in a preconception period, it's not all about testing. I think sometimes, particularly in this era of genomic medicine, we spend a lot of time thinking about what tests can we do, what tests can we do, what can we find, what genetic lab can we send things to. And in reality, there's really not a replacement for talking to your patient. And one of the cornerstones of genetic counseling, and I would make the argument for medical care in general, is a family history review. there's so much to be gleaned from family history that most patients don't even think about reporting to their physician. And certainly in some cases, a family history review can bring to light the need for additional testing. But a lot of times it just brings to light the need for additional counseling. So, when I'm taking a family history, we do it just to evaluate for any additional risks besides what we sort of think about, as that primary reason for referral. So if I'm talking to somebody about PGTA because she's 37, of course, my primary reason for talking to her is her advanced maternal age and her increased risk for chromosome abnormalities and how might PGTA be able to help her with that. But we do a family history review because is there anything else, right? So it gives us the opportunity to talk about things like teratogen exposures for patients who might be on medication. There are often reports of things like birth defects in the family or other multifactorial conditions like autism. And it gives us a chance to talk about those and what those risks are and how we might think about evaluating that patient if an increased risk is identified. And as I said, sometimes testing certainly does become appropriate. And sometimes it is additional genetic testing. Certainly we have patients where we're reviewing family history. And for example, there's a suspicion for a hereditary cancer predisposition, because there's multiple people over multiple generations with cancers. But sometimes it's just as easy as talking about what happens when you are pregnant? Patients will often report, my brother had clubbed feet, my sister had cleft lip and palate, I have a nephew with spina bifida. And none of those are really things that PGT can help with, but it is something that we can talk about during the family history to say, okay, well, what is it that we can do for you based on this family history risk, which is typically an ultrasound evaluation, and as I said, occasionally some genetic testing. But what I always hear when I talk about family history review with, for example, the fellows I work with and my previous job when I worked with residents is, how is that any different than doing just like a quick review of a patient's medical record? And the fact is that it is a lot different, and there's been studies completed that show an actual family history review where you're taking a pedigree and you're asking targeted questions. It depends on the study you read, but somewhere between 10 and 20% of patients are going to have an additional risk factor identified that would have been missed in a medical record review. So this is a really important part of all patient care, but particularly for patients who are coming to begin their IVF journey, to get that information up front before they start. And I would be remiss if I didn't take at least a couple of minutes to talk about genetic counseling and genetic counselors and how they can be very helpful. So genetic counselors are really in a very unique space, particularly in the IVF setting. There's so much genetic testing that can or does happen in the IVF space that this is really an area where genetic counselors have the opportunity to help your practice. By meeting with patients who are going through the IVF process and talking about some of the things that I just mentioned, carrier screening. What is it? Why do we offer it? What might you find? What would we not find? Karyotype, what is it? What would we find? And what might we not find? How is that helpful? Doing that complete family history review. And I really find that genetic counseling upfront can help address patient misconceptions. Patients often come into their IVF journey with some ideas that may not quite be true, particularly as it relates to carrier screening. Often what I hear from patients is, well, I don't have a family history of cystic fibrosis or thalassemia or intellectual disability. So since there's nothing in my family, I don't have to worry about being a carrier for any of those things. But in fact, we know that's not true. We know that at least 80% of people who are identified to be a carrier of something via carrier screening, they have no family history, right? I mean, that's how recessive diseases work. And we know that, but sometimes it's really hard for patients to start to understand that. But genetic counseling can help. And I think also importantly, genetic counselors are there to help facilitate additional testing that might be indicated after you have either test results or family history evaluation. and we can provide that post-test counseling and support, both for patients, but also for our physician colleagues. And we can talk about things like, what does this result have? What implications does it have for your patient? What implication does it have for their reproductive health? And then what else should we do? One of the examples I give here is on expanded carrier screening. Most female patients are evaluated for X-linked diseases. One of the X-linked diseases that is being included in a lot of the carrier screening panels that are available in the US is Duchenne muscular dystrophy. Well, female carriers of Duchenne muscular dystrophy have about a 10% chance of having dilated cardiomyopathy. And for patients who are reproductive age, who have never had symptoms, they may not, again, without carrier screening, they may have never known their status, they may have never known this risk. And it's really important to facilitate that initial cardiac evaluation and screening before you have a pregnant patient, right? Because if you have a patient who has the beginning of dilated cardiomyopathy, that might be something that's really important to know. And genetic counselors can help to facilitate letting the patient know what that is, helping the patient to understand those risks, and then getting them to the right place for evaluation. And these are just a couple of references. I'm sure you guys are familiar with most of them, but the carrier screening study that I referenced is the last one here. So if anyone's interested in taking a look at that. And with that, I think I stayed right at 21 minutes, and I am happy to take any questions that anyone has.
Dr. Sheila, that was a lovely presentation. So if there are any questions, you can post it in the question and answer box. Looks like your presentation was good enough for them not to have any questions.
Well, if there aren't any questions, I don't want to delay the next session, but I have a question. Can I ask a question? Am I allowed to ask a question? Because obviously I practice in the US and I'm not as familiar with how medical care works in other countries. So I'm just curious, is carrier screening something that is offered to patients who are coming for IVF services in India? Is it something that is, is it ethnicity-based? Is it not? I'm just curious what the landscape is there.
Right now, what I understand, the carrier screening is being offered in cases of donor programs, that to select couples who actually ask for it. So carrier screening program is offered for the donor and the husband of the recipient, but not as such for all the patients. Only those patients who have some genetic disorders in their family, of course, they are undergoing genetic counseling.
Got it.
But not as a routine to all the IVF patients. This is what is my understanding. I would like to know from all the other esteemed panelists present here, what is their experience?
Ma'am, I'd like to pitch in here.
Yes.
Sorry. Yes, you're right. We do not offer extended carrier screening unless the couple has a strong family history of a genetic disorder. Because the Indian market is quite price constrained also. So we just, on indicated cases, we do perform carrier screening, but right now it's large and widely used for oocyte donors mainly.
Yes, that too only in select couples, and if they ask.
Only selected patient we are doing the genetic counseling, otherwise we are not doing.
Yes. Are there any other questions? Otherwise,
Dr. Rashmi, there's a question in the chat box.
Okay, let me just see. Yes. So yes, there is a question. Some countries make carrier screening mandatory for IVF. Please express your views on this. So Dr. Sheila.
Yes. So so I'm a genetic counselor, which means I don't think any genetic testing should be mandatory. I think that it should be available and patients should be counseled about the risks, benefits, and limitations. But there are very few things that I think should be mandatory. I do think that it's something that patients should be offered. So I do think, my opinion is that I do think it should be required for it to be offered and discussed. I do not think it should be required for patients to do it even before IVF. Just as I don't think it should be required before patients have a pregnancy, like a spontaneous pregnancy, should be offered.
Okay, so there's one more from Dr. Praveena Pai. Just a second. Yeah, would you recommend carrier screening for couples opting for PGT? And is there any added benefit?
So, I would recommend carrier screening be considered by anybody. So for carrier screening, the benefit of doing it is that if you identify a high-risk couple, you can then offer them PGTM. So it's not really related to, so carrier screening doesn't really have anything to do with the availability or the utility of PGTA. Chromosome screening certainly does. If you have a patient that you're thinking about offering PGTA for, I don't think it's unreasonable to look at their history and see is there any sort of indication to karyotype this couple before we go down the road of PGTA. And again, it's primarily because you want to make sure that they have correct information about their likelihood of producing a euploid blast, but also because some translocations are not amenable to being identified on PGTA, and you really want to make sure that you've got that information ahead of time. But for carrier screening, that's sort of independent of PGTA. I would talk to patients about that even if they weren't doing PGTA.
Yeah, so I think one important message maybe here that if we are going for PGTA, then it's a good idea to do the karyotype of the couple to rule out any structural chromosomal disorders. That's right, Dr. Sheila? Is this the message that you're trying to make? So,
and I would say it's reasonable to consider that. So I want to be, I understand that it's not something that might be readily available for everybody. It's not something that's done in the US either. It's not that every couple is routinely karyotyped if they're seeking IVF. But I think sometimes it's overlooked when it's appropriate. And so I think it's really important to sit down with the patient's history, get their medical history, their family history, and then figure out, like, if I offer them a karyotype, what is the yield? Is there something here that makes me suspicious? Or is this really a couple with absolutely no risk factors at all, and so the yield is very low? But I think sometimes we forget to think about a karyotype until there has been many miscarriages, someone who's had multiple implantation failures, patients who have this long-standing history of not getting pregnant, but no other obvious reasons on their fertility workup. And those are the patients that I want to make sure are being evaluated by karyotype.
Great. Okay. So if there are any more questions, otherwise, maybe we can proceed to the next session, Dr. Ved.
Hello, Sanketh.
Yes, sir. Yeah, thank you so much, Dr. Sheila and Rashmi ma'am, for I would like to introduce Dr. Rahul to introduce our moderators for the panel.
Yeah. Ankit, can you hear me?
Yes. I'll be sharing the screen.
Yeah, I think I am disabled for the video. I'm not able to start the video.
Me too.
Okay, technical glitch.
Yeah, can you share this slides, please, Sanjay?
I'm already sharing it. No, it's not visible.
No, it's not visible.
1 second. Yeah.
So proceeding with the next session, that is the panel discussion. And for this, I have the proud privilege to introduce the moderators for the session. First is Dr. Rajvi Mehta. She is one of the leading embryologists of the country, and ma'am is already there in the field since last 3 decades. And ma'am has the honor of having PhD under Dr. T.C. Anand Kumar. Ma'am has published papers in reputed journals. She is also an invited speaker for various international conferences. Ma'am is currently executive member of Academy of Clinical Embryologists, ACE India. She is in charge of Indian Fertility Society, SIG on holistic medicine. Currently, ma'am is academic consultant with CooperSurgicals and scientific consultant to Trivector Biomed. Next slide. Yeah. And the next moderator of the session is Dr. Ruma Satvik. She is consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. She is the co-convener of Indian Fertility Society SIG Group of Research Methodology. She's been reviewer and teaching faculty and guide with the fellowships in reproductive medicine. Her special interest of areas are ovarian physiology and unexplained infertility. Over to you, ma'am, the session.
Rahul, and I thank iHERA for inviting us. So first I will invite the panelists. So we'll have Dr. Suresh Katera. He is from Singapore and one of the very renowned embryologists with lots of experience. So welcome, Dr. Suresh. To save time and to get most of our panelists, I'm not going to go into their detailed CV because all of them are quite well known. Then we have Dr. Shweta Mittal Gupta. So we have a clinician here. And Dr. Shweta, welcome. Shaileja Gada.
Thank you. Can my video be enabled? I'm just asking the host. Thank you.
Yeah. And Dr. Shaileja, so we have a very, very strong, experienced geneticist here. Welcome, Dr. Shaileja. Then we have Dr. Ritu Hari, again, a strong geneticist with her PhD in reproductive genetics in UK. So we have these geneticists here. Can I have the next one? Dr. Pranay Ghosh. Again, I would call him more of an embryologist. So we have a good blend, very well read. Welcome, Pranay. And then finally, we have Dr. Sachin Hongurtikar. Again, he is molecular PhD in clinical and molecular embryology. And so we have somebody from the genetist. So we have a very, very strong panel. And on behalf of Dr. Ruma, maybe she would like to say a few words before we start. Over to you, Dr. Ruma.
Rajmi, just a moment. So everybody can enable their videos by themselves. We are not controlling it. So if you will see on the side in your participant list where you unmute, you will also have an option for the video and you can enable it by yourself. Thank you. Thank you, ma'am.
Thanks, Shibra. Thanks, Shibra.
Thank you.
Okay, Dr. Ruma.
Please go ahead, Dr. Rajvi.
Okay. So the topic for the panel discussion today is troubleshooting, right from the workflow to the interpretation of results. And after the very nice talks that we've had in the last hour and a half, a lot of these questions have been resolved. But like they say with Murphy's laws, anything that has to go wrong will go wrong. And we are hoping that these esteemed panelists with all their experience will help us to prove Murphy wrong. So without much ado, I would like to really move on to set the ball rolling. So we'll start something very simple. It's the laboratory setup. And we know the biopsy forms the preliminary aspect of PGT. And therefore, we always say that you need an experienced embryologist because if you don't get a good number of cells correctly, then what's the point of the geneticist? So Dr. Pranay, what do you say when you say an experienced embryologist for biopsy? What would you refer to as in terms of quantity, in terms of experience, as well as qualitative experience?
So before I make a comment on the experience of the embryologist, I would also want to make it amply clear that the lab has to be well prepared to be making a transition towards starting PGT, because there are ample number of programs who are doing good work, but doing day 3 transfers. They're very comfortable with day 3 vitrifications and warmings, and they have good implantation rates and good live births. But we know from this panel that we have had on previous occasions with iHERA that not everybody is very comfortable with day 5 blastocyst culture, day 5 vitrification warmings. So you have to be an exceptionally good center with regards to day 5, day 6 culture, vitrification and warmings, because we know that some of the top embryologists, they are a little hesitant to culture their embryos till day 5. So an experienced embryologist may not be somebody who has decades of experience behind them. An experienced embryologist should be one who is routinely doing day 5 cultures, doing day 5 transfers, very comfortable in the skin with doing single embryo transfers, achieving the set implantation rates that has been put forth by the Vienna consensus, and you can gauge yourself whether you are performing well or not. And only then they should be making a transition towards embryo biopsies. We have had a couple of lectures who have given up the number for the quantum of the biopsy that I have to be performing under supervision. So anywhere between 30 to 50. But with regards to your micromanipulation experience, at least 1,000 ICSIs, as Dr. Fiona has said. So this is what it probably takes to get the ball rolling.
So a lab and the embryologist. Dr. Suresh, would you like to add anything to what Pranay has said?
I think there are 3 things to be considered. One is the expertise of the embryologist in terms of micromanipulation skills. Now, when they set a number, 1,000 ICSI cycles, it actually, takes maybe several years for someone who is working in a moderate center, where the number of cycles are not a different skill. Actually, there are some who pick up these skills quickly, and they may be in a better position to manipulate the embryos. So setting certain numbers, people, some of them may not improve at all actually in doing this. Secondly, a setup, where they have the necessary equipment, including a laser. Thirdly, whether your laboratory is properly quality controlled, to deal actually. Maintaining a laboratory, to achieve, good quality embryos is something, very important actually. With this, setup, one, I think, can start, doing biopsies actually.
Okay. So now you have talked about the laboratory setup, the skills of an embryologist as an embryologist prior to biopsy, and now coming to biopsy. Many people prefer, would you advise people to have an in-house genetics lab? How many clinics? So maybe I could address this to Dr. Sachin. How many clinics in India do you think have an in-house genetics lab, especially associated with ART clinics? Or what would you recommend?
Not many labs are having a genetics clinic, genetics laboratory as well as the embryology side by side. But if it is there, it would be well and good. But it is not a compulsion, something like that. You need to have a laboratory, since the embryo biopsies can be transported in the cold chain. I think that should be okay, because not every laboratory will be having that particular this one, so that, and maintaining the NGS equipment and running cost also matters a lot. So
Yes.
that is a concern. Both can be in the different place. That should not much matter.
It's not really cost effective to have a genetics lab associated unless you are a very large organization.
Exactly.
Okay.
Can I add
Huge
to
numbers of the biopsies.
Yes. Yes, somebody wants to. Yeah, Dr. Sharma.
Dr. Shelja here. I would recommend not to have a in-house genetics lab, because the kind of experience you get in a centralized genetics lab with handling the workload is much more than a individual lab. So interpretation of difficult kind of results is always going to be a challenge if it's an individual lab. A centralized lab can have much better resources, and they have experience with handling different kind of samples.
Okay. Now coming to that, we are going to be transporting the samples, any kind of tips or common errors that you have found that people make, post biopsy in where things could go wrong? Maybe Dr. Ritu or Dr. Shailaja?
I think transportation of trophectoderm cells or the blastomia should be in a cold chain manner. Especially the dry ice shipment has to be there, otherwise the cells will degrade. Many a times we have seen cases, we have an in-house genetic lab, but few cases which are coming from outside as a reference. If the dry ice evaporates or anything, we have complications in getting DNA. So transportation is an issue, but then now it is majority wise taken care of. And also, what is the other question? Sorry, Dr. Raju.
No, so basically what things can go wrong during transportation or when the embryology lab is transferring the cells to the genetics lab? What are the common mistakes that you see? One, you said that if the cold chain is not maintained and you don't get any cells.
Yeah, other than that, I don't find anything because nowadays everybody is experienced. Every embryologist is quite experienced to biopsy minimum number of cells and, tube them well. So I don't find any other reason or getting wrong anywhere apart from the cold chain supply.
Proper labeling of the samples becomes very important, especially if there are samples coming from multiple patients from the same center.
Okay, and any risks of contamination with genetic material or microbial contamination, do you find that?
Not really. I think that way the embryologists now are trained very well, so those kind of issues are not normally faced.
And we always include negative control with our, specific biopsies. Especially in PGTM cases, we include negative control. So we rule out kind of contamination.
Okay.
Also, if you can take this question from the, Dr. Ritu, if you could take this question from the chat box, which asks if there is a time duration during which the tubed TE cells need to be is there an upper limit or a lower limit, or you could sort of collect and
No,
then 4 or 5?
There is no minimum time limit or maximum time limit. Now all the courier service operates very well, and within 24 to maximum 48 hours, we get the shipment on time. So as far as dry ice chain is maintained, there is no time limit. It's fine to get it anytime within a week.
All right. What about PGT-M embryos? So you, let's say, go through the first cycle, there are just 2 blastocysts, those have been biopsied and tubed. And clearly they're not enough to give you a reasonable sort of diagnosis with reasonable certainty that yes, she might have an unaffected embryo. So she goes through a second cycle, and this time probably a second round of blastocysts are biopsied. So the waiting period here is 30 days. The question is that all right? So the first round of blastocysts are still there, and now you have a second round and you send them all together.
I would recommend for PGTM cases that the embryos should not be frozen and rethawed again and then, biopsy. We have to take the biopsy in the single cycle, then try to, go for the next cycle. So once the embryos are biopsied, it's better to ship them and then do the initial processing of the DNA, etc., and keep it in your lab until you get the next set of embryos. It's not advisable to biopsy or freeze or, rethaw it.
Right.
It's always good to check maximum number of embryos, especially in PGT-M or SR cases, because especially in autosomal dominant conditions, we need to have more embryos, minimum 8 to 10 number.
Right.
Yeah. It's already discussed. I specifically wanted to ask you in terms of PGT-A for aneuploidy testing in cases of ART. Is there some kind of recommendation on minimum number of blastocysts available? The question question can be that if you have three blastocysts available, then do you really want to do a PGTA and select one for aneuploidy testing, or would you just want to just do the transfer? I mean, just do the transfer and see what happens.
Minimum requirement for PGTA, but well, it depends on indication. Normally, PGTA is offered for, nowadays patients with many number of embryos or patients with recurrent implantation failure or miscarriages. So if you have minimum 3 numbers, that's fine to go ahead. I don't find a problem to keep a cutoff or something like that. Out of 3, you may find at least 1 normal. And sometimes I have seen as per, RIF category of patients, you get to know the reason why the cycle is failing, why the transfer is failing after transferring top quality blastocystis, because in RIF group of patients, some of them have all the embryos being abnormal. So we can have an idea that next cycle we can collect more embryos for such category of patients. So we should not wait for PGTA to have a minimum cutoff. That's what is my belief.
Any comments from, say, Dr. Shweta? You have a patient with
so
two embryos,
Yes, so for PGTA, I don't like to pool embryos. So if there are 2 and I know that this is what I have, then I would just go ahead and do, because the problem, I'll tell you the issue. The clinical issue is the cost. When we are dealing with PGTA, it's per embryo, but when we are dealing with PGTM, then the cost is same, whether I send 4 embryos or 8 for the analysis. So when I'm looking at PGTM, number one, I'm looking at what is the chance that I would get a normal, non-affected embryo, which would be much more, and depending upon the mode of transmission. And that is why I will definitely pool embryos if I'm looking at PGTM. However, for PGTA, it doesn't matter. So it could be per embryo, whatever is the biopsy and the charge. The patient need not go through multiple cycles for that particular indication.
Right. So Dr. Shweta, this one is for you again. So we do understand that PGTM is being ordered to rule out a monogenic disorder in the family, when, especially in cases of recessive, carrier status amongst both the husband and wife. At least that is one of the more common reasons why it would be ordered. The other is recurrent abortions, and you see that one of the partners is a carrier of structural rearrangement of chromosomes. I want to ask you when and what are your indications for PGTA, and maybe each one of the panelists would take this. Because we find less and less support for PGTA. M and SR, we have clear indications endorsed by most bodies and societies. What would be your indications for PGTA?
I think for PGTA, I still, believe in shortening the time to pregnancy. So if I'm looking at improving the efficiency of my IVF, then yes, as a routine for my patients who are trying with self-oocytes above 37 years, the female partner's age, I do discuss. It's also because maybe we are a center, we are geared up to do these biopsies, and so this counseling comes more easily to us. And then, so advanced maternal age, and then also in my RIF cases, yes, I would do that. But I get a karyotype done of a couple after, we listened to the previous lectures, I had a couple from Canada. It's only after 10 IVFs that we realized that even though I was doing IVF for endometriosis severe, but basically the male partner was harboring a balanced translocation, and PGT said a repeated, anomaly. So that is what I would be majorly, these 2 reasons why I would be doing it.
Dr. Pranay, would you like to take this? A remains in the gray zone. I mean, we are still not certain if it's helping in RIF, if it's helping, especially in women with advanced maternal age, fewer embryos, somebody raised that. And it might be a tool for embryo selection, perhaps in women who make too many embryos. Maybe you could then say, you could go through PGTA for selection. But what are your views on this?
This, Dr. Uma, one more indication where my patients, they ask for it is when they've had a previously affected baby, irrespective of the age. So even that, they want to do that. And even I've had incidences where they've taken donor oocytes because of age, but they still wanted PGTA because, they want to be very sure. Yeah, Dr. Pranay, you just go ahead.
Yeah, I'm here to be a party pooper, as always. But the only PGTs that we offer are the PGTM and the PGT-SR. And the only times that we are ordering a PGT-A is to look for euploid embryos to be worked upon using a PGT. So our order of working is only the euploid embryos undergo PGTM or PGT-SR. So we even reserve the pre-PGT workup for the couples. I'll tell you what our problem is. It's not working for the patients that it should be working for. So patients who are 39 to 42 years of age, they end up making 2-3 blastocysts, and they are looking. We use this as a tool for closure.
Right.
We use it as a tool for counseling, and
Right.
none of their embryos come out to be euploid. They don't go PGTM testing or even the pre-PGT workup, which is cost prohibitive. So that is the only time that we use PGT-A for. Other than that, the patient's request is that is it.
Okay, all right. It's quite clear.
Yeah. So now coming to patient counseling, the first question, I'm talking from a patient's perspective. The first thing they will come up is PGT-A going to increase the chance of pregnancy? Or is it just reducing time to pregnancy? So as we understand that we are just doing a selection of the embryos, and like Dr. Ruma rightly said, then when you have a lot of embryos, it helps reducing time. So what do you answer the patient? Is it increasing the chance of pregnancy? Or, like Dr. Pranay said, if you have 3, what is the point in going ahead with it? Dr. Suresh, what would you like to take this?
First of all, I think there has to be an embryological counseling along with the financial counseling to make them understand what are the chances actually in terms of pregnancy and the cost factor involved there actually. Now, without having done that, I mean, we cannot give false promises that saying that it will increase their chance actually. And here I want to point out that in women with advanced age, when you talk to them, you'll have to give the reality in terms of blastocyst formation. And then I would think that considering their financial situation, whether you can offer more than one cycle so that it can be pooled and then utilized. That's what I feel actually.
Okay, I think that's pretty reasonable. Dr. Shailaja, would we say that, once a PGT-A has been done, would you counsel the patients that despite that, there could be a problem? Or is there, how do you counsel the patient that, or in the case that you have a PGT-A and you don't have any normal embryos, you have aneuploid embryos or you have mosaic, would you be counseling them beforehand that they may need to be, they be willing to transfer those aneuploid or mosaic in case they don't have normal? And would a healthy normal embryo lead to a healthy baby?
Yeah, so pre-counseling is very, very important, where you need to explain all possible conditions to the patient. And again, once you're ready with the case, then again at that time, one session of counseling, once the results are ready, is again very important. And again, reiterating the fact that though the results are normal, but there may be other conditions which may not be picked up on this testing. So you have to explain all this to patient multiple times. So pre-test counseling is definitely very important. And again, their understanding at the time of embryo transfer that there may be conditions that are likely to be missed out.
Okay. Dr. Sachin, would you, is it mandatory to recommend a PNDT after PGT amniocentesis or after a PGTM?
I would strongly recommend PNDT prenatal testing for the PGTM cases, considering a slight 5% to 10% chances of the allele dropout issues with the PGTM cases. But for the PGT-A, I don't feel that amniocentesis, such an invasive procedure is required. Just a routine screening like NIPT, that should be fine, making sure that everything is healthy pregnancy.
I think Dr. Rajvi,
and I think everything is related to. Sure. Yeah, go ahead.
What I have a belief on doing a prenatal confirmation for PGTA and SR, we can do an NIPT, being a non-invasive test to confirm the PGT results. But when it comes to PGTM, we now have great panels being developed which can be run on NGS, which has greater than 99.9% sensitivity and accuracy even to check allele dropouts. We do something called haplotyping. So in such cases, I don't think a prenatal confirmation is mandatory. But then, as Dr. Sheila pointed out, pre-counseling session, we must mention as a rule of thumb that prenatal confirmation can be mandatory in case the patient wish to go for it. But the specificity and accuracy of the genetic test now, especially in PGTM, has increased to a greater level. It does not require a CBS or an amnio for confirmation.
Would any of the other panelists, please, if you have anything to say?
So I recently had
a
patient. I recently had a patient of mine who had gone through a PGTA, and she asked me this question: that do I need any other screening? And my genetic department said no, other than an NT-NP scan, we really did not offer her anything more. So I don't know, but right now we are not offering NIPT as a mandatory test for screening in PGTA. For M, yes, the screening is there, but for A and SR, it's not there.
Perhaps from a medical legal litigation point of view, maybe, I mean, to safeguard, there should be no reason for you to be telling the patient that there was something that they could have been offered. And just to be sure, making it clear, we don't offer it as well, but just a point that crossed my mind.
Counseling and consent is what is important. So every step needs to be explained to the patient, and then a written consent needs to be taken, documented.
Yes.
Even the test limitations needs to be mentioned during counseling. That is very, very important. The genetic test limitations plus allele dropout ratios, or it differs from panel to panel what you use, disease to disease. It's an autosomal dominant condition, so the chance of testing on prenatal increases. When we say 5%, it can be 10% error rate. It's very important to tell the patient during counseling, depending on different type of diseases. Recessive conditions have different limitations, dominant conditions have different, X-linked have different, so it depends.
Dr. Uma?
All right, yeah. So, so while you are counseling the patient on why she needs it, perhaps what are the benefits, what are the limitations, you've offered her the alternatives. Now, also one would have to give idea on the timelines, the cost it takes, and eventually what is the chance that she will have a disease-free child. And because that would be the end of counseling, you have to add those points as well. So one important aspect of PGT remains the stimulation protocol. And the clinician here was Dr. Shweta. Would you like to tell us if this is any different from your regular stimulation protocol? And what is it that you're aiming at through your stimulation?
Yeah, so I think that I think very differently when it comes to PGTA, because it comes as a routine IVF cycle, and we have already counseled that this may not be, because it's not increasing the cumulative live birth. So you may be a bit more relaxed when it comes to PGTA. But the more responsibility, I think, comes when we are dealing with PGT-M and PGT-SR, because you need more embryos. We know that for sure the biopsy has to be undertaken. So my protocol, yes, I need more embryos. I know that I have to give more oocytes to the embryologist. So my stimulation would be standard. So if I take in, for example, say a 25-year-old lady, where for a normal IVF, I might have given maybe a 150 unit of dose, a starting gonadotropin dose with good ovarian reserve. For this girl, I'm going to be giving maybe 75 units extra. So this is the kind of thinking thought process I would be doing. I'm going to look very keenly into my ovarian reserve for this patient, the ovarian reserve for the patient. The protocol would be the same like an antagonist cycle, what I normally do. But I also give importance to baseline FSH in such patients. Sometimes I cancel these cycles. I give them some little bit of OC pill. I need a better cohort. then I know that I have to stimulate these patients more than required. And yes, on many occasions, the trigger would be, you know, an agonist trigger, because we know they're going ahead with elective freezing. The reports will not be available. So I don't want them to go into ovarian hyperstimulation at all. So I'm very happy. Antagonist cycle, a standard dose. I need more sites and an agonist trigger. For a repeat stimulation, whether it's a luteal phase or it's just a follicular phase the next cycle, I'm okay with both. If it totally depends that how many times, how stress the patient is feeling. Sometimes they're not ready for a luteal phase, but if I have to quickly accumulate more embryos like in PGTM, yes, my patients are always counseled for 2 stimulations, especially in PGTM. Not really for A and not much for SR, but for M, yes. And how many blastocysts? I said for A, it doesn't matter much. It totally depends how many blastocysts she forms. But for M, for an autosomal recessive, I have calculated, I recently saw 10 patients wanting HLA typing for thalassemia, and I calculated that odds with the geneticist, and I realized that about 16 blastocysts would be required, because 1 in 4 will be disease-free, and out of which 1 in 4 will be an HLA match. So it's a very, very impossible target to achieve, but maybe about 8 embryos we are looking for M, and maybe 5 or 6 for SR. If I'm not wrong, I mean, the embryologist can correct me.
Yeah, no, Dr. Shailaja could take this. What are the numbers of blastocysts one is looking at? So it would be an unusual request to have HLA matching or typing as well, along with monogenic disorder. But if one does have that request, what would you say, Dr. Shailaja, should be the ideal number of blastocysts that one is biopsying?
You're mute. Dr. Shailaja, you're on mute, yeah.
Sorry. It's all the blastocysts which are undergoing testing need to go in for HLA testing in case we need to do a HLA match for transfer. Then all the embryos would have to go for HLA match.
All right. So does that lower the probability of finding an embryo that is disease-free and that is also HLA matched? Because you're trying to do 2 kinds of sort of...
Definitely. So you may have, like, we have experienced conditions where you have normal embryos, but then they may not necessarily be HLA matched. So then the decision needs to be taken whether to go ahead with those transfer or not.
Dr. Raj, would you like to go ahead?
Yeah. So coming to day 3 versus day 5, I think is there anybody still recommending a day 3 biopsy of cleavage stage embryo, Dr. Suresh and Dr. Pranay? Or is there any role of cleavage stage embryo biopsy anymore?
I think from the convenience point of view, someone might actually also, in terms of cost cutting, which they do a day 3 biopsy, and then like freeze. I mean, put it in the freezer, culture the embryos up to day 5 actually, and then send those cells actually, so that you don't pay for all the embryos if you are doing a day 3 actually. Of course, it's almost obsolete unless otherwise in countries where there is legal restrictions.
So if I may add, we have to we have faced patients who have done their homework, who come from fly in from outside, and who insist on they know that these are the options, day 3 versus day 5, and they insist on a day 3 biopsy and a transfer in the same cycle, so that the results can come in within the stipulated time. But we try to dissuade them for the same, because first our testing laboratory that we are in liaison with, they no longer accept day 3 biopsies anymore. So, but this is the only scenario that previously we had a lot of requests coming in, but we don't counsel them to do that anymore.
And
Okay,
also,
Dr. Pranay,
I would like to add
please
here,
go ahead.
actually, if someone does day 3, removing a couple of blastomeres, though we say, the embryo is totipotent, the amount of inner cell mass that is contributed when it becomes a blastocyst would be, I think, reduced. And this is what I remember in the early 2000. People used to say that, the implantation potential will almost be, halved, as compared to an embryo which has not been biopsied actually. So there is a scientific reason, why it shouldn't be done actually. And then, of course, obviously, you get more cells, when you do a, blastocyst biopsy.
Yes, that reminds me of a seminal study done by, if I can just comment on a study by Nathan Treff and Richard Scott, where they did a double embryo transfer using day 3 biopsy. So they transferred a biopsied and an unbiopsied embryos, and following they preserved the DNA, and following the delivery of after the live birth, they did a buccal swab of the newborn, and they tried to correlate and find out the implantation rates, and they tried to find out whether it was the biopsied embryo, biopsied day 3 embryo, or the non-biopsied day 3 embryo, and they found a significant and drastic reduction in the day 3 biopsied embryos vis-a-vis the non-biopsied embryos. So I think that was a pivotal study that shifted the focus from day 3 biopsies to day 5, apart from the Massenbrook et al. Yeah.
Right.
This technical issue, because we have already had a lot of discussion in the previous talks. So when we talk about the different platforms available, Dr. Sachin, can you just tell us, is there any, I mean, today it is NGS. Is there any role for any of the earlier platforms that were being used?
Yeah, most of the people now have shifted to NGS. Previously, they were used to do on fish, but again, the limitation of the fish was again only 5 probes it used to screen, but and RACGH also has not that great resolution wise. Now everybody is talking about next generation sequencing. But yes, fish is needed some in very like limited time, but only the concern with the fish is the technicality of the fish is a major concern. Like it has a several washing step where we need to lose the cell. When we are using a blastocyst biopsy, hardly 5 to 6 cells will be there. So repeated washing of the in the fish procedure, we may lose out the cells, and at the end of the day, we may not get any cells for the analysis. So that is something which is so currently NGS has become like a gold standard method compared to any of the previous methods also.
In terms of cost, is there a big difference? Because in all the discussions earlier, we were primarily focusing a lot on the cost per embryo all the time.
Not really. Only the thing is the pooling is the only concern. Like you need to have a minimum of volume based upon the number of samples. And very importantly, to point out the difference between the fish or fish 5 probes and compared to that, or fish 9 probes also, compared to the NGS is what we have seen according to our experience is most of the IVF pregnancies where we see the aneuploidy is associated with chromosome 15, 16, and 22. Apart from 13, 18, 21, and the sex chromosomal abnormality, the most common is chromosome 16, 22, and 15, 16, 22. Those are the quite common. So if we are screening for all the 23 chromosomes, that would be better compared to that of the fish. And cost-wise, yeah, only the volume is the concern. And now the more number of new algorithms have come across so that we can detect the mosaicism. That is one of the advantage using the NGS. Whereas fish RACGH and the multiplex, this one, fish will be not helping out that one. And segmental deletion duplication is one of the interesting thing to find out in the NGS. But whereas RACGH falls behind compared to that of the NGS.
Okay. Dr. Ritu, this is specifically concerning uniparental disomy. Is there any platform that can be used to detect it? Does it affect reproductive outcomes? This is a question which has actually come from a clinician. So,
actually, I still believe in fish technology because we have been doing a lot of translocation cases, PGT SR using fish probes. So those category of patients are usually normoresponders. They are not infertile and they get a lot of embryos, plus their only problem is either miscarriages happening due to Robertsonian translocations or reciprocal translocations. So as per my experience, even though when I have run NGS for those patients, I have seen abnormalities pertaining to those translocated chromosomes only. So what benefits I outweigh doing a fish is, of course, cost-wise, because probes specific to those two translocated regions are quite cheaper compared to doing an NGS cost, which is per embryo. And then you can pull up embryos in one cycle. I mean, you can pull up embryos and do collectively fish on, you know, the last cycle or something, once you get a minimum number of embryos to be tested. So I see advantages of fish in PGT SR cases, but not for RIF or aneuploidy testing. And then array CGH, as a geneticist, I have got not much idea about it because I haven't used array CGH for PGT-A or SR or M. But then I believe array CGH is not that cost effective compared to NGS. NGS is cost effective. Coming to mosaicism, in my experience, I haven't seen any mosaic embryos from past 6-7 years. I think mosaicism is a concept which is being hyped a lot. But then when you do proper biopsy, you do proper whole genome amplification methods, or even, you know,
She doesn't know anything either.
methods, you don't see many mosaic embryos.
Kill me
So
now.
I believe in genetics, each technology has got its own limitations, its own advantages and disadvantages.
Firangi fellow left now.
We should categorize each technique depending on limitations, and we should outweigh the advantages and disadvantages, and then only with proper counseling we can advise the patient. And I always believe doing a low resolution NGS, because you don't need a lot of data doing a high resolution NGS. Low resolution of aneuploidy testing in terms of A or SR will provide you enough details, and clinician will be happy with your results, and that much is only required. If you do a high resolution, you are actually adding on the cost. So low resolution is more than enough.
Okay. Now I hand over to Dr. Ruma. Now the reports come down, and as a clinician, all the queries that come down to her.
Yeah, thank you, Dr. Rajvi. I mean, these are more sort of just a bunch of cases that we come across during our practice, and sometimes don't know what terms like, you know, let's say a high mosaic mean, what is a mito score. And so totally, I'm told that this is a mixed audience, and I'm hoping there are some people here who don't know that. So this is just a short case history. Could we go to the previous slide, Dr. Rajvi, just before this? Or I remember this case. I could. So this is a lady who has undergone PGTA for a structure. Could you go back to her history, clinical history? One slide before this.
Yeah. This is the.
Yeah, I can't see it on my screen.
This is the first.
For a Robertsonian translocation, it's written in the...
Right. Robertsonian translocation, and the female partners had 2 pregnancy losses, and she's able to make 7 eggs, undergoes IVF. These are the 3 blastocysts that were biopsied. And the report says first is euploid/balance, second is high mosaic, third is euploid. And the question here is, which one would you want to transfer first? And usually it's the embryologist telling us this is the one that I would want to transfer. So Dr. Suresh, would you like to tell us what are your criteria after a report like this to let us know which is your preferred blastocyst for first transfer?
I think it's based on how we have scored before we send the sample. It's a morphological thing where we'll look at the sufficient inner cell mass
Right.
That would be my first criteria now to look at.
So it
rather
remains
than-
morphology.
Yeah.
All right. And what importance do you accord to mitoscore value?
I think when we, it depends on the number of embryos that you have actually. That would be secondary rather than the morphology.
All right, but what does it mean?
Sorry, I didn't get your question.
So what does mitoscore mean?
I think it's the amount of mitochondrial DNA that the laboratory gives actually us, based on that. But I think that's not the primary criteria to select an embryo for transfer.
Right.
That remains secondary.
Right.
And again, it depends on how many embryos have. I'm not sure at actually how much that will determine the outcome actually. Probably those in the service they offer they would be able to comment. Probably Sachin would be able to tell more about that.
Yeah. So Dr. Sachin, what importance does one accord to mitoscore value, and why mention it at all if it's not a factor at all?
For the mitoscore, as far as whatever I have come across few papers, what they say is the mitoscore is lesser is the better, the mitochondrial score. Like what the concept, I think a few years back, there was a paper published where they claim that when the when we look into the pre-implantation embryo development from the oocyte to the blastocyst, the oocyte will be having more number of mitochondria. As the embryo grows into the further stages of the development, the mitochondria number equally gets divided.
Right.
Now, if at all it does not get divided, if the mitochondria accumulates more, there is an unequal division, then there will be a increased mitochondria or the increased mitoscore. So only always they say that the mitoscore is lesser, the always better. And also they compare with the mitochondrial, this one to the energy metabolism also. The metabolism also is when we see into in the starting stages of the embryo development, it will be very high. And as the embryo grows, there will be a lower metabolism, or also what we also state is as quiet embryo hypothesis, where the lesser the better, the best embryo will be having the quiet metabolism. So that is related to the mitoscore again.
All right. Thank you. That's quite useful. So we're not going to take questions 4 and 5. They have mostly been answered. But let us say in the previous case, number 2 was the only, let's say, 1 and 3 were clear aneuploid embryos, and the only embryo that they said was a high mosaic. What does one do in a scenario like that? Completely abandon the cycle? Or what does one do?
So if I may, also
Yes.
if I may make a comment on mitoscore. So mitoscore has to be taken in conjunction with the morphology and the euploidy status, as Dr. Suresh mentioned. And my biggest reservation with the use of a mitoscore is it cannot be interpreted without having a context of the euploidy or the aneuploidy status of the embryo. So mitoscore being in the reference range for an aneuploid embryo has no meaning at all. So
right.
Therein goes your hypothesis that the embryos with lower viability, higher repetitive processes kicking in, higher mitochondrial level as compared to. So mitoscore doesn't hold value. So your second question.
Look at it only if the embryo is euploid. And then again, it's your morphology which comes first. And would you still give any importance to it if morphology was similar? I mean, it's probably number 3 in the list in choosing the kind of blastocyst that you want to transfer.
I mean, it is a proof of concept. If I was, and I would go for a single embryo transfer, that is the third variable that I would score over and above euploidy, the morphology, and then this, unless I was using a time lapse. But my reservation again is that normal mitoscore for an aneuploid embryo has no meaning. So mitoscore by itself has no meaning.
We get
it. Your second question regarding mosaicism. So higher degree mosaics, again, everybody would say that pre-transfer counseling and you have to take the patient in confidence and disclose it to them what low-level mosaics and high-level mosaics and their implication in terms of achieving a good implantation rate or a higher miscarriage means. But I think we should dissuade the transfer of high-level mosaics where the abnormality level is more than 50%, which falls between 50 to 80%, because they are definitely associated with lower implantation rates. But equally more important is they are going to have higher miscarriage rates. So we don't, these patients, we really don't want a higher miscarriage, because these are patients who we don't want to be abandoning the treatment or having a delay of 3 to 6 months because of a miscarriage. So we wouldn't want to transfer high-level mosaics, as is the PGDIS recommendation.
In any case, all right. Could we go to the next case, Dr. Rajvi? Okay, now here is another structural rearrangement case with pregnancy losses, who the only blastocyst that she has, the result has come out to be no DNA detected. Now, what are the reasons? What does one do? The questions are, we are faced with this dilemma. Do we do a repeat biopsy? Do we transfer without biopsy? I guess an embryologist would have to answer that.
So yes, if I may, the commonest reasons are working on an embryo that is of poor quality and not having cohesive cells that have been sent across for biopsy, or you have you haven't done the tubing in a proper way at all. Or these are the most common reasons for a no call. So again, we'll have to discuss with the patient what needs to be done. I mean, if it was a single grade A 5AB day 6 embryo, and if 5AB is a suitably good embryo, even for a day 6 one, we can go on to rebiopsy the embryo. But again, it has to be the patient.
Risks are just way too many. That would add 2 procedural costs, 2 procedures, and the kind of strain and stress that it's placing on the embryo. All of that will have to be considered. So in this case, of course, the blastocyst was transferred on the request of the patients. You can see she's a 42-year-old, and in fact, the first child was born through PGTM and was normal, is normal, about 3 years now, and this was her IVF for a second child. So she underwent a blastocyst transfer after full counseling without any of those procedures being indicated. We presently have a positive result on HCG, but the question is, and the genetic counselor says that if she continues, she's most likely normal. If she aborts, that will be your test, you know, that is perhaps she's a carrier, that she carried the mutation. Could we have the next case?
Yeah, but in this case, often, you know, the patients may start questioning. I mean, do we really start questioning the whole idea of PGT?
Why, yes.
Such cases.
Yeah, does one do that?
Yeah, okay.
So we do know that pregnancy losses that happen because of reciprocal translocations or Robertsonian translocations, there is a good probability of a live birth without any of these testings also. We do know that. So yes, and that can be explained.
Yeah.
So now this is a lady with 2 IVF ET failures. So she's undergoing this for repetitive RIF. And the 2 blastocysts that she's made is showing these results. And it does look very scary. So Dr. Ritu, would you be able to interpret this for us?
Yeah, I would love to answer this question. As I previously said, for RIF group of patients, we get to know an answer if chromosomal aneuploidies is the major cause. I've seen in many of the RIF patients where all embryos, minimum 3 to 5 tested, comes out to be abnormal. So we know the reason. In such scenarios, we can ask them for more embryos, or else the patient can go for a donor option. My experience, 2 of the patients have tried here with PGTA. The first cycle also 5 embryos were abnormal. Second cycle also around 4 embryos were abnormal. So you get to know an answer. However, in this case, she have already had 2 IVF ET failures, and then seeing the PGTA results, I feel the abnormality, even if you transfer one of the abnormal embryos, if at all after counseling patient willing to, it would not lead to an implantation. It would be a failure.
Right.
Obviously, we'll not transfer the monosomy 15 and trisomy 21, but we'll try transferring the first one, which will again 99%, I feel, will lead to implantation failure.
Right. Her question is, what are her options for future? Does this repeat? Does this go on in her next cycles? Is it because she says her karyotype is normal? How is it that the embryos that both hers and her husband's karyotypes are normal? How is it that this will repeat again and again?
It can actually, because the gametes get quite susceptible to such kind of abnormal segregation. So if the oocyte is susceptible to abnormal aneuploidy segregation, she can have abnormal embryos in the next cycle as well, provided we get maximum number of embryos. If we test around 5 to 7, then we can have a choice to actually select if we get some normals. But then if again among 5 to 7 all are abnormal, then she can opt for a donor option. That is what I believe. It can repeat.
Right. Dr. Shweta?
Yeah.
Yeah. So this is actually a patient that you treated. Would you be able to tell us what would your alternatives
So, if we look at, it's very simple. That is what we all follow, that if there are complex abnormalities, we don't transfer these embryos, because the whole purpose of offering PGT-A is defeated then. Because when I must have counseled this patient, we were ready that if this is the kind of report which comes in, we will not transfer, because this is the answer we are looking at. And if you look at the chromosomes, not a single is repetitive. So it is like a pure what Dr. I think Ritu Hari just told us, the segregation issues. So we are not looking at, missing a karyotypic abnormality.
Right.
I would not transfer. Complex abnormalities, I would not.
I think we concur on that. The question was, what are her future options?
Yes, so depends on how many IVF. She's already had 2 IVF failures. So now I will be counseling her for donor oocytes, and why not? Also, we look at the duration of infertility and the kind of treatment she's gone. So probably she would be like a prolonged unexplained infertility. Then yes, I would like to change the oocytes then.
All right. All right. And we move on to the last case, which is a lady who's undergone a PGT-M for thalassemia. Both she and her partner are carriers, and they've had 2 pregnancy losses in the past. The second one had to be terminated. And after 3 IVFs, she makes 7 blastocysts, which were then sent for testing. And you can see the results are basically results of PGT-M. And of course, what was not ordered was a PGT-A. So this is a 30-year-old, and I'm sure the clinician had her reasons, or the patient had a reason for saying no to the PGT-A. But the question is, do we routinely order aneuploidy screening with PGT-A, with PGT-M? Is it necessary? Remember, these are 3 IVFs that she has had to undergo to make these blastocysts.
Ruma, I can just pitch in as a clinician that what counseling I do, I look at the age of the female partner, and if she's young, then I don't offer her PGT-A at the moment with M, because that risk, also when we hear about mosaicism and things, so it's better to put it and then do an antenatal screening, because her risk of aneuploidy is low. So for a 30-year-old with just 1 single normal embryo right now, non-affected, I wouldn't have offered her. I mean, of course, this is in retrospect, but even prospectively, I wouldn't have.
What would the geneticist say? What would Dr. Sheila Johel say? Would you say, is it necessary? We can't hear you, Dr. Sheila Johel. Sorry.
I agree with Dr. Ruma, because if the age of the patient doesn't indicate the requirement for aneuploidy testing, then you can do without aneuploidy. Again, you need to explain or counsel the patient the risk and benefit of both the procedures. And accordingly, let the patient decide or take a call whether they want to go for aneuploidy. Like so at the same time, if this patient was more than 35 years of age, then you would counsel this patient to definitely go ahead, spend that little additional and go ahead for the aneuploidy screening as well.
Right. The other question is, what are our, how much do we rely on these results? Now, Dr. Ritu did say that there is a possibility of allele dropout in such cases. And I believe this discussion happened that in PGTM cases, one would need to offer some kind of testing while the pregnancy is underway. So Dr. Ritu, would you like to elaborate on what is the chance that this report, what is the chance of an abnormal report being false positive, and what is the chance of a normal report being false negative?
As I can see, as per the report, there are carrier embryos as well. So I feel the chance of having allele dropout or a false positive or a false result is dropped down to around 2%. When you say a carrier embryo, the embryo has obtained one allele from mother and one from the father. I mean, sorry, one from either of them and one from the normal side. So carrier means your chance of allele dropout is reduced to even to less than 2%. I don't find any allele dropout in this report. However, as a rule of thumb, I would still counsel the patient to undergo a chorionic villi or amnio procedure to confirm the PGTM results, because this particular case has been done on PCR followed by Sanger sequencing. It has not been done on NGS. If it was done on NGS, it would have been 99.9%. I would say the chance is 98% for it to be reliable. There's 2% still it can be, error.
Yeah. And that kind of confidence exists across labs, Dr. Sachin, the 2% false negative or false positive rate, does it exist across labs or across all platforms?
Yeah, I believe that all the technologies has any DNA technologies has the limitation of 2% error rates. That could be probable. So only I always feel that the prenatal diagnostic confirmation is necessary. Although it is like most of the time it will be a matching, the results will be matching, but just to on the safeguard of this one and make sure that whatever we have found out, it's absolutely fine. So it's 2% is across all of the any genetic laboratories remains the same thing.
Right. Thank you so much. Just that this lady did undergo, why I bring this up is because maybe this should be a part of counseling as well. So this lady did undergo an amnio at 16 weeks. And while this came out to be negative, the result was confirmed. The PGTM result was confirmed. Aneuploidy status was also confirmed. So the euploidy status was confirmed. The lady went into preterm from and of course lost the pregnancy at 21 weeks. Very, very unfortunate for her. There is just that it's a counseling point, not that we change our confidence in the report. The report remains where it is. So I hand it back to Dr. Rajvi to sum up the panel for everyone.
I think we've had a very interesting discussion. I have one last question to the geneticists and the embryologists here. What do you think is the future of cell-free DNA? Are we going to be going for it in the near future? Then it just one quick word from all of you. Where do you see it in the near future?
I think it's promising. We have to wait and watch how it progresses. Whether it can add in addition to what they are looking at, combined blood-cell fluid as well as spent culture.
Yes.
Can it come up with more tests, something like viable embryo and all that, that's looks really promising actually.
Dr. Pranay, any last words on that?
Yeah, so since 2016 to 2021, it has been 5 years that the concordant rates haven't really gone up from 85 to 87%, and this has been the trend. And I really, again, am skeptical on this as well, because it necessitates a total change of how you culture your embryos, and every lab cultures their embryos differently, how you analyze the media, spent culture media. And I think the recently available commercial platform, the Embrace, it requires you to culture all your embryos till day 6 in a specified manner. So it demands a lot of from the embryologist in the way they are used to working with their embryos. But definitely, I think it can be a add-on like time lapse, but it's not going to replace the invasive testing.
Okay, that's your opinion. So let's see what time says. And we have just 2 last questions from the audience, so we'll just take it up. What is the possibility of the role of artificial intelligence in predicting the success of PGT in IVF? Anybody wants to take that?
Sounds futuristic.
Yeah, because well, everything there's nothing like you can have. And another one, maybe the geneticist. What is low and high resolution NGS in PGTA, and how will it be helpful to the patients? So maybe a quick word. I think we've covered it earlier. And the final one is, in a patient indicated for PGT-SR for balanced translocation between chromosome 15 and 17, what is the chances of finding aneuploidy in other chromosomes, and how will FISH help if aneuploidy is present in the other chromosomes?
It depends on indication. What is the indication? Did the patient have previous miscarriage, or did the patient have had previous IVF failures?
Unfortunately, it's an anonymous attendee, so I don't know what the thing is. So
Okay,
then in that
so
case,
like only for miscarriages, I would do a FISH pertaining to 15 and 17th chromosome, because FISH technology can actually reveal me uniparental disomy, which NGS and other platforms fails to do so. There is an involvement of chromosome 15, so I believe there is 1% chance to be UPD, that is uniparental disomy. I would do a FISH and confirm the result. If it is for RIF case or previous failures or kind of advanced maternal age, I would go ahead with NGS.
okay. So I think we come to an end of this session. Thank you very much. Thank you, Dr. Ruma, and thank you all the panelists. It's been quite enlightening to have such specialists in the group. So thanks, Dr. Pranay, Dr. Suresh, Dr. Sachin, Dr. Shweta, Dr. Ritu.
Thank you very much.
Thank you, the iHERA
Thank
team.
you.
Okay, thank you.
Bye-bye.
Dr. Ved.
Thank you.
Rahul.
So thank you, Dr. Shailaja.
Yes,
Your camera was off, so I missed it. Yeah.
Yes, thank you to the esteemed moderators for moderating this wonderful session, and thank you to panelists as well. Now for the vote of thanks, I would like to invite Dr. Sanjay Shukla to kindly sum up the day of today's day.
Thank you, Rahul. It was an exhaustive day, or maybe exhaustive evening today. All the speakers, all the panelists were bang on the target, and probably the dilemma that we started with, many aspects of the PGT might have cleared in most of the audience's mind. Just to, I mean, we discussed everything, right from the techniques to the scientific background behind the PGT and the newer things like the NIPT and cell-free DNA and all. And I'm very optimistic that in future we may not be doing the invasive procedures, but in conjunction with the morphokinetics and metabolomics and cell-free DNA type of things, I mean the NIPTs, we may be able to, and yes, some audience has also asked about the artificial intelligence. So with everything combined, we may be able to pick the most suitable embryo to transfer. Still, there is something behind all of us who governs all those things, and whether we will be able to achieve pregnancy in every case may not be in our hands. Anyways, so thank you all the speakers, all the moderators, and our wonderful audience who stayed with us for almost 3 hours. And on behalf of iHERA, I thank you all and hope that you will be available as and when we require you with your expertise. Thank you very much.
Thank you. Thank you.
Thank you. Thank you.
And before you go away, I have something very special to show if I can share my screen. This is from my lab. A few hours ago, I just clicked this picture. Can I, Sanketh?
Yes, yes, please, sir.
Yes, sir. Yes, sir.
Okay, so it has nothing to do with the PGT, but very interesting case. Share my screen. Okay, can you see this?
Yes.
Yes.
So this
Yes.
particular patient had 23 eggs. She is very young, 28 just. And almost all the eggs had very thin zoni. And out of 23 eggs, I think 10 eggs were amorphous. They had large vacuoles and some artifacts also. You can see some artifacts in this particular oocyte also. And there were 8 M2 eggs which were looking sort of normal that I injected. And today when I went on to check the PNs, I found this one. The cytoplasm is herniating from the site of injection, I guess. And you can see one PN in the cytoplasm, which is inside the zona, and one PN in the cytoplasm, which is outside the zona.
Yeah, they have divorced even before the marriage.
Yeah, so this is something which very interesting.
What was the cause of infertility in this case, Sanjay? Was it anything very
I think
unique?
this particular patient had tuberculosis, and she is on the anti-tubercular drugs for almost an year. But otherwise, everything seems normal. So, yeah, I'm
The progress looks like they're not in good terms, sir.
I hope age is on limit side now.
Yeah, age is just 28.
Oh.
Yes. So let's see how it goes, and I'll share if we can get some.
Yeah.
Do you expect something from this?
So,
God knows sometime miracles happen now.
So I wish you happy evening and happy weekend.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye.
At the end, I would like to thank you, CooperSurgical also, who supported us, and Dr. Shipra is here, and Dr. Vakil is also here. Thank you so much. Thank you. Thanks to everyone.
Thank you, sir.
Thank you so much,
iHERA.
sir. Thank you very much, sir. Thank you.
Thank you.
It's our
Bye-bye.
privilege. Thanks. Bye.
Thank you.
Bye. Bye.